Hi, my name is Peter. I'm a specialist in emergency medicine from Denmark and working in Stockholm the last 6 or 7 years. Um, Today I'm doing the lecture that I did a few days ago for the YDAM, the Young Danish Emergency Medicine organization, which I'm a member of and a board member of as well. And we have these not run by me but run by other awesome people like Christian, and we host these events where we invite someone in to talk about a topic that they like, and preferably case based and so on. So this is my lecture from one of these events, and I'd just like to share it and do it in English so everyone can maybe learn something from it, hopefully. So the topic of this lecture was, as it often is with my lectures, non-technical skills and specifically in decision making in emergency medicine. And I was asked to do neurological examples, as this is one of my niche interests, I guess, and also because the one who invited me, Christian, he gave me a great opportunity to think outside of the box with my presentations, because he presented me with a challenge of trying to speak a little bit about, like, when we have something that seems obvious, like a hip fracture, but actually turns out to be a stroke, and how to get around that problem. And what I came up with is this lecture on mimics and chameleons. And but I will be touching on a lot of the same topics that I usually touch on in decision making, but in a little bit of a different way. So I hope you would like it. All right. So this was the poster that he made, and and this is the workflow. So the lecture is in 3 parts, whereas the 2 last parts are the biggest ones. I will probably use more time here than I did during the lecture to describe some of the things in more detail. But just a few minutes about where I work. I haven't done that in English, so I'll just quickly talk about that. And then the theories that are relevant for the cases afterwards. So first of all, where do I work? And just a small introduction. I've been blessed and lucky to be involved with certain projects. I've done this. I've not been an editor in this book, but I've done a few chapters in this book. And if you want to read what me and Emil have come up with about probabilistic thinking, then this is a really good chapter 1 in this book, where we go into details about that. But the entire book is great, and not made by me, but made by Emil and Annie and Lasse Paludan and a lot of other great emergency physicians in Denmark, who have made this incredible book that I happen to be invited to be an author on. And it's case based, and there's just a lot of great emergency medicine thinking that is not anywhere else to be found in Danish. So it's a unique book, and if you haven't read it or seen it, I strongly recommend it. And of course I am biased, but it's built on a lot of the principles that I keep talking about in decision making, and how we need to teach decision making skills in emergency medicine. So this is a great Danish title. I'm the editor and editor on this book, and we are currently working on a new edition that will be probably coming out in late 2025 or 2026, early 2026, and I'm the sub editor on chapters about mainly the anemia, neurology, psychosis, headache, and some biochemistry chapters as well. So Um, then I'm also proud to be creator of Acute Medicinen.dk. I've done a lot of blogs there earlier, and now I mainly don't do that many blogs anymore. I usually do videos, but I do from time to time do podcasts. But right now it's mainly Emil Iversen who does like most of the stuff with his team of a small but really strong team of people who helps him with it. Yeah, I've done several blogs, and you can check out them in the Acute Medicine. And I'm also a course instructor internationally and nationally in Sweden in EMCC, the Emergency Medicine Core Competences course made by Eric Driver. I've done that for around 10 years now. And yeah, then I'm a founding member of YDAM, which this lecture is for, right? And then I am also a part of this book called it doesn't really have a, maybe Eric calls it something. It's the Checklist Compendium, I think it's called. It's a book that we give out and can be bought by homepage Alibris. And we update it every year, and me and Emilia, we try to go through it every year. Me and Emilia Juleson, emergency physician that I work with, and is one of my good friends. We edit it every year to try to update it so it has the most recent value and knowledge. And it's a really great like book to have in your pocket. Probably, again, I'm biased, but probably one of the best around here in Scandinavia. And since you're here, you may know that I do have a YouTube channel. I don't get any money out of it, and my main driver for this is putting out lectures and putting out knowledge about this like emergency medicine expertise that we want to build in Scandinavia, and trying to, like, a lot of these things are my blogs that I've made into lectures. A lot of things are I try to go through different angles of these topics of non-technical skills and neurology and dizziness and headaches and stuff like compassionate care and non-technical skills and so on. So if you like this lecture, then please check out some of the others. If you want to, you can subscribe. Then you'll know when I do a new video. I don't post regularly, but I do maybe a couple of videos a year. And the most important thing for me is to share the references in the videos and to share this expertise that we all need to show the rest of the the rest of the medical community that we are actually a specialty in Scandinavia that has an expertise. It's not just being able to work in an emergency department. There's an expertise and a knowledge base behind that. And even though many people have worked in emergency departments in Scandinavia because of their like AT or KBU or something like that, they need to start there. We believe that you don't become an expert by just practicing there. You need to actually know the stuff, and that's so it would be weird for a endocrinologist to come down to the emergency department and just the other way around. It would be weird for me to go into an endocrinologist outpatient clinic and just do like an entire day there. And we don't so that seems weird, right? But it doesn't seem as weird that a endocrinologist expert comes down, like outpatient doctor comes down to the emergency department and then like goes through a lot of patients there and like without asking, automatically seems like they're an expert there. So there's like this mismatch or a double standard that we have to challenge in emergency medicine, and we do that with knowledge and with expertise, and that's why I'm doing these videos. Okay. Yeah, and the videos that are turning around, those are the videos relevant for this lecture. All right. I've shown them before, but some of my favorite books for emergency physicians in the topic of neurology are these three. This one is a great just how to examine a patient and how to do like what are the golden nuggets of things that you have to take away from the when you examine a patient. It's really great. This is an all-round great book by Daniel Conciela and Gunhild Valdemar. Daniel Conciela, I know, is a neurologist, German-born neurologist working in Rigshospitalet in Copenhagen, but educated in Sweden, I think Gothenburg. But he has like a great mind for educating in neurology, and his book is definitely worth a read for any doctor, especially emergency physicians and probably neurologists, because of its very bedside. It's very bedside focused, and yeah. And then this one by Aaron Berkowitz, who also has a great, like, you can search for podcasts. He's part of podcasts where he goes through the mindset of neurology, and is really a good book. Also for like a localization-based approach, which is one that I usually present in neurology. This is a good, like, these three. If you have these three, these are golden. All right, for decision making, I can mention lots of books, but really good. Like, if you only need one, then this one is a really good, like, case-based book by Patrick Croskery, a professor in emergency medicine. These other two is I haven't read both of them. I have them, but I haven't read them in entirety. But they are case-based books. One in neurology or neurological emergency, like medicine, and one in general in emergency medicine about the same topic of, like, why do we miss stuff? Why are there cognitive biases? And yeah, all these three books are good. If you only buy one, this one. This one has Justin Morgenstern as a foreword. So yeah, these three are great books for decision making in emergency medicine. But these are only case based. If you want more theory, you can check out some of my other lectures on what to do. I would always like Patrick. I love Patrick Croskery's work. He is a little bit, as I understand it, more towards the System 2 Daniel Kahneman camp of decision making, as he has made a lot of books on like patient safety, and that narrative is often spinned like, we have to prevent accidents, and that's why biases we have to de-bias ourselves. And the other school of thought is the more System 1 reliant Gary Klein book called Streets, Lights and Shadows. So that's the counterweight to Gary Klein, I guess, and Daniel Kahneman are the two counterweights in this discussion, and we'll go through that as well. But these are some good books to read on that counterweight kind of problem. All right, and of course there's lots of foam out there. Check my blogs out, and check Justin Morgenstern's blog out about these things, and you'll see links to all of the important areas of this topic. All right, so first of all, where do I live? I live in Stockholm now. I've done that for 6 or 7 years now, and I moved here because of mainly family. As you might have guessed, the salary is sadly worse because of the worse crown. Like the rates in Sweden are quite bad compared to Denmark. But there's lots to gain with, like, private family life, because of their, like, when you have children, it's easier to have time off, depending on where you work, of course, and your situation. But in general, like, because of parental leave, even though Denmark is good, Sweden is better, and especially the cultural thing about parental leave is, like, even though we could do it as doctors in Denmark, and I hear that it's getting better, being a doctor is a zero-sum game. If one leaves, then the other that are left must bear a higher burden, must bear all of the shifts in your absence, and that can create a culture of, why are you the one to get to leave because I have children at home as well, or I have other things that why are just the people with children prioritized in this? Why should I not be able to go to holiday when you have children at home? And so it can create, like, this culture of overworking, and to some extent that is like an inherent problem in all zero-sum cultures, I guess, and especially at our line of work. And it's definitely not as bad in Scandinavia as in a lot of other countries. Probably this is one of the best parts of the world for this. But Sweden, culture-wise, at least at our workplace, where I work now, it's very accepted that you do parental leave, that you do sick leave if you're sick. Then of course it's problematic if a lot of people are away, and then we'll have to talk about it. But in general, it's accepted culturally, and that's a huge relief. And that's one of the like main things that are really great with being a doctor in Sweden, or at least in Stockholm, where I work right now. As you know, I've done a blog on experiences from. Sorry, as you may know, I've done a blog on experiences from Stockholm that I did the first couple of years that when I was here, and I was kind of culture shocked because I have worked in the capital before in Copenhagen, but I came from a smaller hospital when I came to Stockholm, and the culture shock just by being in a big city hospital again, but also by being in a health system where it's heavily privatized, and not a lot of the privatization is not always controlled. So a lot of like, especially for the patient can go anywhere they want in the system because there's lots of entrances. In Denmark and in Norway, there's only one or two, maybe three entrances. Ambulance if you're really sick, your own doctor, and then in some places, in some areas, you can by phone like 1813, which is 1177 or 1177 in Stockholm. You can like call, and they can then advise you to go to the emergency department. But in Stockholm, you can it's open the emergency departments. You don't have to have a note from a doctor to go there. You can just go there, and so there's and even for us doctors working in Stockholm, it's really hard to advise people where to go when they become sick so there's a huge crowding problem when all the emergency departments are open and you can just go in, and also all vårdcentrals are like they're not closed. You can shop between vårdcentral and vårdcentral if you want. It's not totally easy, but you can do it. And there's also Acute, where you can like I guess it's called urgent care instead of emergent care. So you can there's lots of ways in, and along with all of the private sectors that close at or like bank hours, then you have a system where it's really hard to guide patients where to go, depending on what they have. So a lot of people end up in the emergency department, and we have like long waiting hours. Maybe you're lucky if you come to an emergency department in Stockholm and you wait less than maybe 6 to 8 hours, depending on the day, and depending on the place where you go, and time of year. But that's a normal in a lot of countries, and maybe we're just unique in Denmark and Norway that we haven't had that much of that problem yet. But it seems like maybe it's because of vårdcentrals, because of like Einlæge, the primary practice physicians are getting more and more to do. My dad is a private practice physician in Denmark. It seems like the amount of stuff that they are carrying a lot of the healthcare system. The healthcare system is built upon them, because they need to see patient, and then they need to they are the gatekeepers, so to speak. And because if the gatekeepers are overworked, then the gatekeeper function is usually out of function, and you will see that more and more people are getting into the hospitals, meaning that they will be crowded. That's what you see in all other countries, besides Norway and Denmark, and that's kind of what we're seeing. But what we haven't been seeing in Denmark since private practice physicians became a specialty I think in the 80s or 90s. But yeah, so there's lots of differences, and there's more differences, but that's like some of the common mentioned ones when you come to Stockholm. All right. Just by comparison, just so you can get a feel of it, this is the entirety of Sealand is kind of the same size of the entire area of Stockholm, or like the municipality of Stockholm, the region of Stockholm, and so vaster distances, especially if you're pre-hospital and the ambulance working from here. That's why we have helicopters and all. But if you have if the ambulance or the pre-hospital doctor car is out here, then going to here is problematic. So they've dealt in the city in south and north, but sometimes you need the car. You only have, I can remember, 2 or 3 cars. I did a lecture on that on the pre-hospital care, so check that out. But I can't remember right now. But it's a big area to cover. That's what I'm saying. But I work in the center. And there's a couple of hospitals. There's Södertälje, which are off the center, and then Norrtälje, which is 60 kilometers off the center as well. And you have the more central hospitals, Danderyd, NKS, New Karolinska. This is an error. You just ignore that. But it's right here in Solna, which is kind of like Rigshospitalet, Rigshospitalet in Copenhagen. And New Karolinska Solna is together with New Karolinska Huddinge, which has its issues, to say the least, because of the quite big distance between them. And then you have SÖS in the island called Söder, Södersjukhuset. And then you have Sankt Göran in the island of Kungsholmen, which is where I work, right here. So it looks like this where I work. It's we have approximately 420,000 inhabitants. These facts I kind of haphazardly got from our homepage. I am not sure how current or up to date they are, but just to get a feel of it. So we have a quite big area. We see around 100,000 to 150,000 visits per year. It might have changed because there is more and more coming every year. All specialties, we have all specialties, including PCI and pacemaker and so on, but we don't have the surgical niches, thorax and neurosurgery, vascular surgery, and so on. We do have something like what you call the sensory subjects in Denmark, like ophthalmology. We don't have that. Ophthalmology is placed in one hospital, St. Eriks in Stockholm. Only one place have that. And ear, nose, and throat, there's only one of those in Stockholm as well, in Huddinge, and there is a sub-department in Karolinska Solna, but there's only an emergency department that is open for everyone in Huddinge, so everyone has to go quite far away to get ear, nose, and throat problems. So that's why we do see a lot of these patients, but we don't officially have we don't officially see them. We can start their care, but we don't have professionals. We don't have ENT doctors here to help. They always need to go somewhere else if we can't fix it. Then dermatology we don't have. And there's some like internal medicine stuff that we don't have, rheumatology, and this is so. This entire lecture I had to translate quite quickly, and I with Copilot. So it's some of it is AI translated. So I'm not sure what nephrophilia is, but we don't have rheumatology and we don't have nephrology. But we do have, and we don't have interventional radiology either. So we're kind of a moderate-sized Danish hospital with a big emergency department, and one of the differences on a hospital level from Denmark is that we in Sweden, like in Denmark, there's like emergency department, and you have departments, and then you have your intensive care. There's no like in betweens. There's no step up and step down. We have more like step up, step down levels of care. We have like you have your emergency department, and depending on where you work, the emergency department is dealt up into subdivisions. Like our places have a surgical part, a orthopedic part, and a medical part, but the borders are getting more washed out with every year. Hopefully, we're getting to where we might be a totally undifferentiated emergency department, which is, I'm not sure that is the best thing for everyone. I think the hybrid model that we have, where we have the specialties working along with our specialty in the emergency department, might be a good one as well. But at least we know that the old model, where we don't have emergency physicians at all, where we only have internal medicine doing internal medicine patients, that's a bad model, with a higher mortality from which I think was shown in the in a Danish PhD study by I forget his name, but yeah, a couple of years ago. All right. But once you get away from the emergency department, we have like what you call a AVA and a MAVA, like a medical acute care. Like it's like a department for patients that are mainly medical but undifferentiated. And then after a while, it's like a 48-hour department, right? So then they have to go out to the specific departments after these 48 hours. And it's really important to have places like that because usually in emergency medicine, our purpose is not to do the diagnosis. Our purpose is to find out what is dangerous and what is not, and do the patient needs to be admitted or not, and then start the care. But we don't have to end the diagnostic process, because then the patient has to stay in the emergency department for a long time, and we get crowding and boarding and so on. So we need to be able to put up patients to departments when they are not totally done. They're not totally differentiated into whether it's medical or surgical or whatever. So we have a bias towards the medical places. So we have a lot of patients that are medical, and when we do get patients that may have a surgical problem, then it's harder to admit these into these undifferentiated departments because they are more medical biased. But in the great scheme of things, it works quite well, I think. And then from these departments, you will send the patient after 40 hours. Optimally, it doesn't always work like that, but optimally, you would admit them to other medical wards, depending on what is most likely the problem. Yeah, and if we do find out what the problem is from the emergency department, we just put them up to the specific department right away. Then we have then the difference is that we have the higher level called EMA, intermediate emergency department, where intermediate medical department, where I also work. We as an emergency physician, we do work there as well, maybe 10 or 20%, and it's really good, so we can learn to do vasopressors, and we can learn the care in beyond maybe 6 hours, because of boarding in Stockholm, we do need to take care of quite sick patients in the emergency department for an extended period of time sometimes. So it's important to know how to put in an A-line, how to do vasopressors if we need to, how to do NIV or BiPAP, how to do decent fluid management for patients, and so on. And I didn't learn it in EMA, but I did have much more experience with it by being in EMA. So it's really nice that we have that. And then above that, we have the intensive care unit. So we do have a step down. We do have a little more nuanced department choice in Stockholm than I was used to in Denmark. Yeah, and again, I get no money from this, but our hospital is currently going through this filming process where right now there's a season 1 out of our hospital, and they're following these guys. I know a lot of them, Anna and David and Christopher from Neurology, and our CEO Gustav Storm, who was who was earlier my local CEO as well. So if you want to check out SVT, again, the hospital has not my hospital has not paid me or anything for doing this, even though like all cards on the table. Our hospital is private, which is a little bit strange in a like a Scandinavian setting, because I think it's the only big private hospital in Scandinavia. And we work like in Denmark we do like a private practice would work, like it's also private, but it works for the region, the same thing but just on a hospital scale. And I was really skeptical to the privatization in the beginning when I came, and because I thought like the priorities might be shifted a bit and it's money making, and I'm not entirely wrong in that, I think, but I think there's in the system of Stockholm, where there's a lot of bureaucracy, more bureaucracy than I was used to in Denmark. I think there are wisdom behind having to do the thing, like being able to do your own thing, because of the system that we work in, that is quite complex and bureaucratic in Stockholm. But what do I know? I don't know. Maybe I'm just brainwashed into saying these things. I don't know. But it works like a normal hospital when you're there. You wouldn't know that it's not a normal hospital, I think. All right. So, and this is from a picture from my where I live, and feel free to come visit on a study visit. You can contact me, and then we can probably find out a way where you can just follow either me or my colleagues around in the emergency department to see how we work and how things that you might learn, and things that we might learn from you guys, right? So exchange is really important in this specialty. So because everyone does it a little bit differently, and it's good to see how, like, get out of your own department and see that. So please come and visit and contact me if you want. All right, that's enough about Stockholm and the introduction. Now we'll go into some of the theories about today's topic. And usually when I talk about these theories in my decision-making lectures and on the EMCC course, I usually say like, this thing is difficult that we're doing. It's okay if you don't understand all of the details right away. Usually it's best learned through case-based learning with an instructor that knows about the way of thinking, the probabilistic way of thinking, like in the EMCC course. You can definitely practice medicine without this, but I think this is a core thing. It's like axiomal. It's like an axiom in emergency medicine, especially, but in medicine in general, probabilistic thinking. So I think it's fundamental, this, but it can be a bit hard to understand to begin with. So, but it's eased with learning by case-based learning. So yeah, and yeah, again, and this is just like part of a bigger thing where this is from the far side, and it's just what we do as doctors is hard, right? It's hard. It's difficult to diagnose people and to get information from living people, and it's just, so be kind to each other when talking about like cases where you missed stuff, or yeah. Or when your colleagues like, oh, why did surgery do this, or why did the private practice guy or girl send this patient into our department? Is obviously he shouldn't know. This patient shouldn't be here. It's like, you don't know how many other patients they had that day. You don't know the context. You don't know, like, and if it's like, and oftentimes from the private practice perspective, well, they send in one, but they see maybe 20 others. So it's just like that's the gatekeeper thing. But like, we all have bad days as well, so it might be that as well. So just be kind and be professional about, especially when you send the patient home to that same private practice physician, because you don't want the patient to lose alliance with that physician. Again, this is hard, so we all sometimes are out of our depth in certain areas, and then it's better to just send them in, and I agree. So yeah, that's what I meant with this picture. All right, non-technical skills. So I usually talk about non-technical skills and introduce it like this. So all our technical skills are like bricks in a wall. These are the things that, like, we know how to do a lumbar puncture. We do know how to do we do know how to auscultate the heart. We do know how to theoretically treat atrial fibrillation and so on. But non-technical skills, that's all of the the glue, like what's called mortar, maybe. All of the glue that keeps the stones together. And the non-technical skills, there are different ones, right? So there's communication, teamwork, situational awareness, decision making, task management, and so on. There's a lot. This is longer than this, and there's no official list that I know of all non-technical skills. But in general, it's just in a nutshell, it's like the technical skills is what you need to know to like get things done. Or to actually what the technical skills is like what to do, but your non-technical skills is how to actually get it done, how to do it in real life with communication, with actually getting the data points about atrial fibrillation so that you can treat it, knowing like what to treat with, knowing like should you treat this now or should you treat it later, like having situational awareness about where are there other problems in the emergency department that you need to know about, and does this take priority over others, and so on and so forth. Like so, and today we're talking about the non-technical skills of decision making. For the other skills, you can check out the other lectures on this. All right, so I was presented with this case as a thing to talk from. So and all cases are anonymous here. They should not be able to be traced at all. And I've changed some of the facts, but all cases are real, and the cases either I have seen or my colleagues have seen. So this is an 85-year-old woman who comes to the emergency department after a fall at the nursing home and cannot be mobilized. There's no pain in the leg on clinical examination, and this turned out to be a posterior stroke. Again, posterior stroke, not vein. Again, AI translation. But so why was this missed? And is this a miss? And how could we do better? And what is the cost of doing better, so to speak? So let's go into some of the details on that theory. So first of all, if we focus on stroke, then we might have the patient may have a stroke, but they may also have a mimic, something that looks like a stroke but isn't a stroke. We'll come to the 5M 3P. That's a mnemonic to remember which ones it is, but it might be like stuff like hypoglycemia, CNS infection, hip fracture, migraine, TOTS paresis, and so on. FND, like functional neurological disease. So, and then on the other side, you might have something presenting like something benign. Maybe, like in this case, you have someone falling, presenting like maybe a hip fracture or a hip to the or a hit to the hip, and it actually turned out to be a stroke. All right. So something benign being actually something bad, and something bad looking like something bad actually being something benign. It doesn't really have to be. Sometimes you can have something bad that looks like something other bad, like a CNS infection. But it's a nice way of just easily thinking about these things. Either it's a mimic. It wasn't what you think. It's something different, and that's like it's mainly academically list like so. Both of these things is just another way of saying the thing that you thought it was, it's not that. We have to always think about the dangerous stuff. So these are focusing. This is where you focus on the false false positives, and this is where we focus on the false negatives. So I usually say like if the stroke is a wolf, and then the mimic, if it's benign, then it's a sheep. So the mimics are kind of like It's usually like a sheep in wolf clothing. It looks like a wolf, but actually a sheep. And the chameleon looks like sheep, but are actually wolves. So these are wolves in sheep's clothing. It's just a way of seeing it. But these focus on the false negatives. So you see a hip fracture, you test it for hip fracture. It wasn't. So you are falsely negative. Your test for these things, like for stroke, is false negative. You thought it was negative, but it wasn't. And here you focus on you thought it was a stroke, but you over tested. It wasn't. It was actually one of the mimics. So it's more like a false positive. But that's just an academic way of seeing these things. In general, is all of them are like kind of misses, but we only care about the misses that are dangerous, right? In emergency medicine, the ones that are time critical and we should have picked up, those are the ones that we focus on. But that's today's topic. So, what is a mistake in emergency medicine is a nice thing to start off with. So, I often show this great thing from Simon Carley, this great, simple but really great just way of showing. He has a blog in decision making from 2015 called Decision, like making good decisions, where I usually have this is like this should be printed on every emergency department. So it's like just the probability of error in the start of the patient's visit or the patient's diagnostic journey is always higher, right? We're more likely to be wrong about what it is because it hasn't developed yet. The disease manifestation is usually much less. And that's why, like, this is the reason why, or partly why, a lot of things are being said about the patient being seen the day after. Like, so it's not only like the patients that are going into the ward. It can also be like we are seeing a patient that the primary care physician saw. Like again, why? Like because they see them even earlier, right? Or it might even be someone who was sent home from the emergency department. So it might be a colleague who saw them at this point, but then they present, it was an appendicitis, or it was something bad, right? But it was not evident with the data points that we have at the time. And the problem here is like, when I see the patient, that's part of my kind of shtick about this is really this is hard what we do, and it's really important to be professional about it. And knowing this, that when we look backwards, the retrospectoscope, when we look backwards, it seems, why didn't they pick that up right now? Well, because the disease manifestation wasn't too clear, or there might be a lot of other things going on that which we'll talk about. But that's really important to have this like humility. Of course, if there's a pattern at some specific person or specific place often misses things, then feedback is in order. But be kind, right? Be kind and know that, like, take the way of saying this is not a bad apple. That's the old way of knowing. Like, don't do the old way where this is a bad apple. We are the best. We are. We don't know why everyone else sucks. And we just have to go rid of all the bad apples, and there's only good ones left, right? That's what Sidney Dekker calls the old way of thinking about failure or errors, and we should be doing the new way, where we think about the context and where we think about why did, like, the first question to ask is, why was this excellent professional being challenged like this? Why did they make that mistake? Or why did they sick when they should have sacked? Well, and then that opens up a wealth of like, maybe it's something about this patient presented really weirdly, and that we can learn something from that. How to not do that another time, because it seems like I would have made the same mistakes were I in the same situation. So that is a much more healthy and much more I guess it's called a growth mindset kind of way of looking at it, and it's better for everyone, for the patients and for us, and it's more like, I'm not saying that no one does make mistakes and someone actually do have to be corrected for that. I'm not saying that, but there's nuance, a lot of more nuance to all of these things, and we've all been in these situations. So learn not blame culture is so important to talk about here. Yeah, this is from Sidney Decker's book and lectures about the Field Guide to Human Error, which is both on YouTube. You can check out the YouTube channel, and he has the entire book on YouTube, so you can like listen to it and in a short version. It's really great. But he has you have a doctor who, from this like perspective, like there's lots of options. It could be this, it could be this, it could be this. Some of them are problematic, some of them are not. And what this guy sees afterwards, maybe this is an incident analyzer, or maybe it's a doctor on the ward the next day. Why didn't he see that this error here? Why didn't he see that? Because you have the you know now that there was a mistake here. Why didn't he see that? Well, there's lots of areas where there could have been a mistake that was actually that where he saved the patient maybe, or yeah. So I always think about like when you have a patient like Scott Weingart, when you listen to his shadow boxing lectures, he will say that almost always he will give patients antibiotics if they're critically ill, and you don't have a specific like a truly like you don't know yet what the reason for the hypertension is. He will give them antibiotics, and maybe he does a little bit more than I would do it, but in general, I think there's a really big truth to that, because they will be over the threshold. Like if you have a sick patient, then they will be usually over the threshold of actually giving antibiotics, because they might be a sepsis, like a cold sepsis, like a sepsis that isn't febrile. And the day after or the next couple of days, you will maybe only 2 out of 10 will have an infection, but those 2 out of 10, it was really important that you gave them. And 2 out of 10, like 20%, that's really good. So that's how you have to think, right? But was it maybe just 2 out of 100? Then probably it's not. It's borderline important then, and even lower, then you might be harming, right? So it's important. That's how we want to think as emergency physicians. And so when we get feedback from someone after the fact, then it's important that they know our context and they know how our mindset was. So we need to go through cases prospectively then you get these data points, and then you get these data points, and then you get these data points. What have you done? What would you do with these data points? That's what you call that's kind of a shadow boxing way of going through cases, and that's so important also when looking at errors being made, because then we can learn from them. So if you want a bigger walkthrough about this, then go to Rahul Patwari's or Sidney Decker's homepage or YouTube channel where they've gone through this in great detail and for emergency physicians. All right, so this is my friend and mentor in a lot of ways, Eric Driver, who has made this definition work in progress, the definition of errors in emergency medicine. Like, it's failure to approximate the probability of time-sensitive conditions based on available data point of care information. So I would say I would agree with Eric, and an error is not that you had a bad outcome. An error is the process, right? It's more process focused. When you're in the room with the patient, all of the data points that you're collecting should be relevant, and you should also be aware of the time sensitivity, like the patient, like the time you spend on this patient, you don't spend on other patients. So with a reasonable time, time being spent, which data points are most important right now to collect, and with the data points that I actually do collect, have I thought about all the dangerous conditions? Have I ruled them out? And if I haven't, then I have to work them up for that. So that's kind of and if you miss to either collect data points from the history or the bedside tests, or if you miss to think about when you have the data points to actually see the pattern of, oh, this could be a ovarial torsion, or this could be this. It's not when we do wrong evaluations that might be sometimes, but mainly it's we do it in the evaluation, but we have thought about, oh, it could have been ovarial torsion, but I think the risk is too low to actually work it up. then you have thought about it. It's when we don't think about the things and we don't collect the data points. That's where we have the problem. Or the errors could also be, I would believe, in overdiagnostics or opportunity cost. You spend an hour with a patient that has a broken toe, but you don't go into this patient's room where that might be septic. So it's not only on a one patient level, it's on several patients, emergency department kind of view level as well. So yes, you might have made like, I think I can't remember his name, but Brian Goldman. He did a great TED talk where also an emergency physician who talked about, well, how many a baseball analogy, but yeah, how many bats, like a good baseball bats, maybe one in, I don't know, 200, maybe one, I don't know, but like he doesn't miss one in, I don't know, 10, 30, 40, something like that. We are expected to bat one in 1,000 or one in like we're not allowed to miss at all, not ever. Right, and that's a totally stupid culture, right? Because that's important. That we cannot do that. No one can do that. So we work in a risky business with time-sensitive conditions, and as Simon Carley would say, we are probabilisticians, not diagnosticians. Okay, and what I also always share and talk about is, when do we know that enough data has been collected in each case, right? So we don't do like there is a balance here. Like, you might be afraid of missing something, yes, but if you are reasonably experienced and you have when you know this mindset that we're going to talk about, and you or maybe you have asked a colleague and they don't think there's too much to more to do here, then we have to move on at some point. We cannot dwell on each and every patient, because then we would not get anything done. So at some point, there's the amount of knowledge that we have created about the patient is good enough. And when the point is, depends on how critical ill is the patient, how complex is the patient, and yeah, so and how competent is the patient to actually come in again if we miss something, right? So I think these nuances, and lots of more things to say about this, but these nuances are really important to talk about when we're talking about errors. We have to start with what is the definition and what is actually our reality, right? A good concept that I often talk about is also this BDGO, bad decisions, good outcome. Like, we're often lucky, and I think a lot of the problems, or a lot of the smoke, or a lot of the like accusations that we sometimes get as emergency physicians, is that, oh, I used to work in the emergency department, I can do that really quickly, much quicker than you, or I've worked in the emergency department before. That makes me an expert, because no one died on my shift. Like, yes, that might be true, but it's a numbers game, right? So I think Simon Carley says in his bad decision block, or making good decision block and podcast, that, well, while you may get away with not ever, like, you may go an entire career without ever doing an examination on a child for petechia, but if you don't do that routinely, then you will miss the 1 or 2 or maybe 5 in your career. It's a numbers game. It's just a matter of time. And for that reason, we have to have a system based on the time critical conditions. Not a lot of examinations, but the good examinations that are worth doing, like checking petechias on a child, are important to bake into the way we think and the way we work, right? I often give the example, as Simon Carley also does, a bad decision, good outcome could be you just sent home that patient with a thunderclap headache. Yeah, well, 9 out of 10 times we know that it will be good. It's literally 9 out of 10 times, because 10% of every thunderclap headache has a subarachnoid hemorrhage. then maybe 5 or 10% more has something else that might be good to catch, like an RCVS. But you can go through the emergency department and doing things that are not good, but actually not being aware of it because you're lucky most of the time. And we see that sometimes when, like right now in our department, we do see that part of that when we just took over, or a couple of years ago, we took over the surgical part of our emergency department. And where surgeons had worked before, or not really surgeons, but people who were doing a year when they just intensely worked as surgeons. They wanted to impress on their supervisors so that they could get the job as a surgeon, or certain residents. So it was pre-resident surgeons who worked there, and they worked their ass off, and they did a great job in many ways, but they were not emergency physicians. They did not see the entire spectrum. They sent home a lot of patients, and a lot of them may have come back as well. I don't have the statistics on that, but so they might have been able to see maybe 20 patients in a shift, or maybe more. That's really crazy numbers here in Sweden, for a lot of us at least. But where like the norm is maybe 1 per hour, something like that. See 1 patient per hour is like a good, like maybe average. Depends on the day, depends on the patient, and so on. But it's just, yeah. So so that's the so when we took over, it seems like, oh, everything went more slow. We do more CT scans, and yes, but because we think, like, would you send home a thunderclap headache with a 10% risk of having a really dangerous condition? Is that an acceptable miss rate for you? That's the question, right? And of course, a lot of surgical patients might come back if they have more pain, and that might be a wise way to work, and saving CT scans and like that. Or if you could admit the patients for a few days, then you could save a CT scan as well. But we can't do that always. And in the Stockholm system, you cannot be seen the day after at your primary care physician. You cannot be seen the week after sometimes, or even sometimes a month after, depending on the season. So you have to counter that. You have to take that into account, right? So so I'm not willing to miss something like a dangerous condition with 10%, especially if something that's so dangerous that they will not be able to come back for it if it turns out to be that. So another example I sometimes give is, what is this, like, that I actually learned because I didn't know before I came to Sweden. But if you have a gastric bypass patient and they come in with stomach pain, and they have they suddenly and you do a CT scan with like IV and peroral contrast for inner herniation. If that's negative, can you send the patient home? Well, the answer is probably no. I know it's done in a lot of places, but the sensitivity of that CT scan is quite, like, it's good, but it's not great. It's like, I think it's maybe 90 or 95%. That's not bad, but it's not amazing, right? So you would have to always admit those patients to see where it goes, right? Only a surgeon's hands can send these patients home, as we say. And in the places where they don't do this, then they knowingly or non-knowingly accept a miss rate that is quite high, maybe around 10% on these patients, 5% maybe. But usually the acceptable miss rate for most conditions, it's not been studied, right? But in PE, Dr. Klein, not Gary Klein, but another Klein, has studied this to be around 2%, where that's working them up to less than, like, decreasing their risk to less than 2% will make them will be non-beneficial for the patient, because then you have overdiagnosis and you may find clots that you don't need to find, and so on. So I just think it's a really important concept, this, to think about. So the process is important, more important to us in emergency medicine than in the outcome, when we think about whether it was a mistake or not, and whether it was a mistake that we could have done something about or learned something from. Yeah, so good decision, good outcome, that's great. Good decision, bad outcome, that should be great as well. Not for the patient, of course, but we could not have done anything else. because we know we did like sorry, the other way around. Bad decision, good outcome. That's not good. This is where we need to learn, like, look at the petechias of children, right? Do the CT scans of thunderclap headaches within 6 hours and so on. If they have a bad outcome, but it was a good decision, then it's usually second victim. But that's where we should not kick ourselves and actually say to ourselves, we did a good job. Ask a friend to go through the case prospectively. So like, I got these data points, and also talk about the context. Like, this was a really, really busy shift. Here are your data points. You have 2 minutes to think about it. To like kind of simulate what happens. That's my advice, to have a good friend who's also a doctor to go through it with, especially an emergency physician. And then you have like bad decisions, bad outcomes. Happens to all of us. Okay, it's also a numbers game. And that might be a great reason for it. I have missed STEMIs because the patient was presenting with dyspnea, was acutely sick, and was also schizophrenic. Like, it was picked up by the system, like the Swiss cheese model, right? It was picked up. I even had a cardiologist by the bedside who said, "Oh, the ECG looks normal." And then another cardiologist looked at it, who was in the department, and he said, "Oh, this is definitely a STEMI. Why are you sending this patient up? He has to go to PCI." So I've missed, and the ECG was really bad quality, but it was totally evident. You could see that it was a STEMI. So these are problems that like, we can all make bad decisions with bad outcome. I should have thought that, oh wait, this could be a STEMI because he presented with a pulmonary edema. It was early in my residency. I didn't have my mental maps all figured out, and I have a cardiologist who said it wasn't a STEMI. So I kind of didn't look too carefully on the ECG. So context can often be a thing here, but I will go into some of these things in the next part of this theoretical lecture. But even though there's no reason why, like, that was just a bad mistake, then we still have to think about the second victim thing. We still have to think about, we all make mistakes. Everyone can do it. We do it. It's difficult, what we do, and we do it well. Most of the time we do it really well, even though we're also lucky. We also do it really well. That's part of what Jeffrey Braithwaite, I think it's an anthropologist who talks about complex systems and complex adaptive systems, talks exactly about this in one of his podcasts from the BMJ about how to improve the healthcare system from 2018. Check it out; it's great. And it says, like, yeah, but we often say, like, we have 10% errors in medicine in general, but that means that it goes well 90% of the time with these really complex decisions, with these really sick patients, with these really like multifaceted systems that are not ideal, with working conditions that are not that are often outright like problematic for us. Like, not a lot of people would work in this area. Not all people would do that, right? We do it, like, a lot of it is from the kindness of our hearts. Also because we get a lot, like, we love doing what we do, but it's also like, it takes a toll. And yeah, so that's that's the conversation here. So let's go into more like, why do we make mistakes? And I call it errors or mistakes. I think the language here is flawed, as I just went through, like, some of these nuances and what, like, is it a mistake, and what is a mistake really in emergency medicine and so on. So, but we'll just go on calling it a mistake or an error, and leave that discussion of nomenclature to another time. This is Patrick Croskery. He usually says there are 3 reasons why we make mistakes. There's the error-prone conditions, there's the knowledge failure, and then there's the thinking failure, which is suboptimal data gathering and also suboptimal data interpretation. And he thinks that 75% of these is thinking failure. Like 75% of all errors in emergency medicine or medicine maybe in general, is thinking failures. I know Eric Dyer would argue that he thinks it's knowledge failures. maybe especially in Scandinavia or in countries where where we have a medical culture where we don't have to know everything. Like we're not pimped, as it's called, in the same way. I don't know. I think it's I think it's academic to think about like which one is greatest. I think all of them are contributing almost all of the time. And I think we need to be better in all of them. But the ones that we can make better is usually these two. The error-prone conditions we'll talk shortly about now. So Patrick Croskery calls emergency medicine a laboratory of error because we are one of the like as we said, as Simon Colley says, we are one of the more high risk, like it's a risky business that we do. There's sick patients. We have short time to figure out what it is. We have lots of them, and we have to have a system, right? We have to look at the petechias of small children as well, even though it's really rare. We have to think about the dangerous stuff, and so on. So, so emergency medicine is error prone, even for the best of us, right? And the context oftentimes is during the night shift. There's boarding. There's lots of patients, like sounds and so on and so forth. Like it's really important to think about these factors contribute greatly to how we talk about this and errors, right? So there's a system level thing that can be done here. But then we talk about knowledge failure as well. So knowledge failure, like you don't know your stuff. That's kind of it. And there's a lot of stuff to know. There is some stuff that is more important to know than other stuff, though, for emergency physicians. And I would argue that you can come to a quite decent amount of stuff that you need to know on at least conditions. If you think like this, if you take a symptom like chest pain, and then you put it into these, like I usually do this 2x2 table, where you have time critical, not time critical, likely and non-likely. I'll go through it in a little while. But if we take chest pain, then you have six time critical conditions. You can like at home do the Excel file where you put in all of these, so you have a kind of overview of like, okay, for headache presentation, these are the ones that I want to think about. For breast pain or chest pain, this is the one I want to think about, so on and so forth. And then you kind of map out, okay, the time critical conditions. There in chest pain, there's like 2 heart, there's ACS/OMI, and perimyocarditis, right? There's 2 lung ones, which is pulmonary embolism and pneumothorax, and in parentheses maybe severe pneumonia, but yeah. And then but that usually doesn't present with chest pain. It's usually dyspnea as well. But then there's 2 what I call the weird ones. Like there's the vessels, like aortic disease, and then there's the other weird one is upper GI, which is Boerhaave syndrome. It's also pancreatitis sometimes. It's also biliary disease. Sometimes it can be upper GI, whatever, right? Then you do that, and then you put that into this this is like you okay. You have these 6. That's the list. I need to know those by heart. I need to know the illness script of those conditions, right? I need to know how did you present, which kind of what tests are really good to rule in these things, right? Then I don't have to ask all the questions. I just need to ask the questions that are most important, right? And so on. And it's like that's part of the reason why we did the checklist, or Eric did the checklist compendium, to know like which questions are most important. We should still sit down with the patient, ask open in the questions to begin with, to like kind of know what is going on, why are you here today, and expectation management and validation and all of the stuff that I talk about in compassionate care lectures. But we need to do that stuff as well. But then once it comes to the doctor's part, then we need to, okay, I've heard, I kind of know what the problem is now. Now I need to like, okay, could it, you say it's chest pain, okay, and I've heard your story about it. Could it be ACS? Could it be like what are the, like usually we have 3 or 4 things that these are the most likely things it could be. What should I do about them? Well, oftentimes just by history, like I can, if I know that the tests I can ask are really good, then I can just rule them out by just asking these questions and doing that. But sometimes oftentimes I need tests like troponin or D-dimer and so on. So, and I need to know in my illness scripts, like what is the pretest probability of the patient? What does that amount to? Like, is this an elderly, like, I need to know that for ACS, you have atypical presentations, especially in the elderly, especially in neurological patients and in women and so on. So you need to know the treatments, like if this is an ACS, what treatments could I give to this elderly patient? And because if you know that the treatment will not work on them, then why work them up in the first place? Or at least then you have to kind of balance, especially in the ones coming in from the elderly homes. Do I need to actually treat this? If I don't need to treat it, why do I have to work it up? And so on. So that's why we need to know the illness scripts of each of these things by heart. So Ruben Strayer has done, like for each syndrome, he's done, or symptom presentation, he's done this SUN, right? So it amounts to all of these. I mean, I think it's like 150. And there's local differences, because if you hear hoofs in one place of the world, these might be zebras there, but not here. So for instance, Borrelia is really there's a high level of TBE and Borrelia here, so that which isn't in other areas of the world. As we'll come to, there's a high risk of also nitrous oxide toxidromes here right now. And so if they presented with those symptoms, then I also need to know about that, right? So that's knowledge failure. If we don't know, a chest pain could be a upper GI issue, or an upper GI issue could be a chest pain thing, then we miss the patients in the surgical department with upper GI problems, but it could also be a troponin problem, like it could be an ACS. So that would be a knowledge failure thing. We need to know our stuff. I always think to this, I add always these, because usually we don't think about the non-time critical things that are likely, like gastroenteritis. Oh yeah, it could be gastroenteritis. It's almost always, as I said, we almost like it's part of the we're lucky thing, right? Most things in the emergency department are not dangerous, but we cannot diagnose them with certainty. We need to think about the dangerous stuff and then rule them out by history or by tests. But and then what is left is usually like, oh, it's gastroenteritis, or oh, it's whatever. But we don't need to know about gastroenteritis, right? But what we do need to know about are these non-time critical conditions where you where there's a good test, so that by ruling this thing in, you can rule these time critical things out. If you can with high certainty say this is a BPPV, then you can rule out the stroke even without thinking about the stroke. As long as they don't have two things at the same time, which some patients do have, but yeah, we'll talk about that later. Yeah, so that's really important. That's a really important nuance there. So, for instance, BPPV is a really good example of things that you really need to know about, because then you can rule that in and rule out the dangerous stuff. And you can also, but a bad example would be like, oh, this patient, the patient's pain went away when I gave them some like Gaviscon or something that eases stomach acid, right? That's not a good enough test with a high enough likelihood ratio to rule out ACS without troponins. So that's not a good enough test, right? It can still be that. I agree. Especially in young people, then probably yeah. But in older people, no. Then you have to do the troponin, right? So that's kind of like, that's knowledge failure, and that's how we want to think. And you can subdivide these syndromes or symptom presentations into syndromes. For instance, in headache, you can subdivide it into thunderclap headache or CT negative headaches and so on, to kind of make your like, okay, if this test is negative, what is it then? Or so I kind of know things where I need, like, if it's a undifferentiated headache, then I'm not too worried. But if it's a thunderclap headache, then I know there's a 10% risk of this being subarachnoid, then I need to be more aware of things. And I also need to, like, okay, my colleague gave me a CT negative headache. What do I need to think about before sending the patient home? What conditions does the CT scan not rule out? So I can, like, or pregnancy with headache and so on. So there's subdivisions there that you can. In the emergency room, Scott Weingart usually said, like, we should think about it like this. Like, so you have someone with dyspnea. Okay, I don't think about, at least not to begin with. Like, I don't think about, is it cardiac, or is it pulmonary, or is it maybe pH, like it's a compensatory dyspnea? No, I would think about, okay, are these lungs dry or wet? By POCUS, if they're dry, then I will do the scan of the heart, because then I want to know that it's not a big PE, and so on. Like, so you can go on, and then you can, like, so that's also a subdivision in when it's really critical ill patients, right? Then you can kind of want to know about the typical mimics, or typical situations where you have to think about mimics, so you don't go into a trap, like looking for petechia in children, or doing blood glucose. Don't ever forget glucose also in stroke patients, because it might be hypoglycemia. And then you also want to create mind maps and models. So mind maps and models, for instance, are like this, that I've shown in another lecture, and I'll go through it later. Like, that you can fall back on. Okay, you have a patient with weakness. What does it, like, I don't know what it is. What does it look like? What does the gestalt, like the basic, like, where does it, like, what can I fall back on? It's the same thing in the emergency, like when you have a critical ill patient, or the patient have a C problem, they have a shock. Okay, what kinds of shock do I know? I know before, like, something going to the heart. Okay, is it that? No. Is it something obstructive? No. Is it something arrhythmogenic or cardiac? No. All right. Is it something after the heart, like vasoplegia for some reason? Is it Addison's? Is it sepsis? Or is it dissociative? Is it HB? Is it anemia? Is it methemoglobinemia? Is it carbon monoxide? So on. So you have to, like, fall back on some mental maps, and I've talked about that in all the lectures that you can check out. And here's just an example of, like, different ways of thinking about headaches, right? So you can subdivide it into these different systems where you kind of know, oh, okay, it could be this or it could be this. And then the green ones are the ones where CT scans are negative. No, sorry, CT scans are really good. They rule out blood. Not an SIH, that's wrong. Not an SIH, but an ICH and in traumatic bleeds, right? And then all the oranges, this should be orange. All the orange ones, this is where you can, maybe rule out something in certain conditions with a CT scan. So you could, this is all wrong, not all wrong, but the VCV, that's wrong. That can usually not be, that cannot rule out by a CT scan, but post-cellulitis can. I think only SIH and VCV are wrong. But SIH can be ruled out sometimes with like within 6 hours. Right, then then it's a high acceptable miss. There's a good, like, there's a numbers needed to lumbar puncture. There are 250, something like that. RCVS can be ruled out if you do the scan when they have the headache, and if it's an arteriography. Dissections, it has to be an arteriography. CVST has usually to be a venography, and so on and so forth, right? And we also need to, like, we're talking about knowledge and why we make mistakes. We also need to know our tests. We need to know the likelihood ratios and how the instrument reliability are, right? Because can I actually, like, for instance, I usually use the example. So on the POCUS Atlas, there's great sensitivity and great specificity for all POCUS. So why are we not all doing it? Well, we should be. And I'll do a lecture at one point about POCUS as well. But because I use it all the time, and I educate in it as well. But to begin with, especially, I cannot do the same, like, level of ultrasound as someone who is, like, an echocardiographer, or like, I cannot find, like, usually the studies are done by really experienced people, usually. Sometimes they do like try to find out this question, how, like, if a novice did this, how well would they do it? But a lot of the things, like, so there's low hanging fruits in POCUS where it's really easy to learn quickly and get a high sensitivity and get a high instrument rate of reliability, but other areas are not. And the same goes with all other tests as well. Like, there are certain tests that has a really shitty or bad instrument rate of reliability. So even though they have a high sensitivity and high specificity, we would probably be skeptical whether we found it or not, right? So we need to know the test characteristics in our illness scripts of many of the good important tests for the time critical conditions, and these are some of the resources that you can use for it. POCUS Atlas, POCUS Evidence for POCUS, for instance. The evidence-based physical diagnosis by Steve McGee is like a great book about physical examination. The NNT is great for everything. It's becoming bigger and bigger now, and they have, like, for lots of conditions, likelihood ratios and numbers needed to treat as well. And then you have like publications like the JAMA series for like the rational clinical examination, where they put in likelihood ratios, and then for specific areas you need to know the studies also as well. There's this series again. Did this patient have cardiac syncope, for instance? And then they list all of the likelihood ratios, and the studies has to be done in the right context in the emergency department by an emergency physician, so on and so forth. Right. That's what we need to know. And an example here is the HINTS test. To begin with, everyone was really skeptical of it, partly because we used it on the wrong patients, right? And we still do. So I cannot stress enough that we have to use it on constantly dizzy patients that are monosymptomatic and has nystagmus. They must have nystagmus, right? But to begin with, the studies were done by neuro-ophthalmologists like Newman Toker and Qatar, and then there was like, oh, can we actually do it? And we didn't know whether we can do it. Now we have the studies that shows that we can do it, but I understand the skepticism in like 2009 in the beginning, but now we have the studies that shows that we actually, like Vani from Italy, and like have shown that we can do it. So we need to know this stuff, okay? That's part of the knowledge thing. Then we go to the more theoretical thing about thinking failures, either suboptimal data gathering, like how do we gather data? We already touched on it as part of the like communication lectures that I do. Like, how do we gather data in an effective way without doing opportunity cost, without getting too much unimportant data, but getting the right amount of data at the right time, not using overly long time on one patient instead of using it on another. And there is also like suboptimal data interpretation, right? When we see the data points, do we actually get the pattern? Even though, like, you can get the pattern of the Big Dipper on the stars in the sky, but you don't know it. If you don't know it, then you cannot see it, right? The same thing with a lot of the star signs. A lot of star signs I don't know, but they're there to be found out. So we need to know the star signs of the time critical conditions, right? And I always like to quote Gary Klein, and is more a paraphrasing from his book Shadows and Streetlights here, but I usually say, like, he usually says like, it's not about connecting the dots. It's not about just connecting the stars, the starry sky, right? It's actually about also like knowing what counts as a dot. So you might have a satellite up there, right? You might have a satellite floating around, and say, oh, that's the Big Dipper with a satellite. Like, you don't know it's a satellite. Then you might say, oh, yeah, I found a new star sign here, but it isn't, because, yeah. So Gary Klein usually talks about, you need to know what is a dot, what counts as a dot. And he often says, or he says in his book, it's similar to, it's not like putting puzzle pieces together from a puzzle. It's more like taking 5 or 6 different puzzles, like mashing them up together, and then like finding out, like, and then like doing the puzzle, because if sorry, I'm just talking about like a jigsaw puzzle, because if you because then you have to find out, oh, which of these pieces is truly my piece, which are just, oh, nothing to be concerned about, and then create the picture from that, right? So I think that's a good analogy of what actually is the problem here. We both have to gather the data, but we also have to interpret it right. And it all starts with this model. This is from Professor Croskery, but it's by the work of Daniel Kahneman, and others, like also Gary Klein, about like how to think about decision making. So this is the system 1, system 2, or the dual process theory. And so you have an illness presentation, right? And then you either recognize the pattern, or you don't. If you don't recognize it, then you go into system 2. And if you are in system 2, then this is laborious. This is something that you have to think about. You think this is hard thinking, right? System 1 is more pattern recognition, right? You don't even think about it. You just know. And the challenge with this is that even if you're a novice, then you will create patterns. Your brain will create patterns, and if you act on those patterns, you will be wrong a lot of the time. You will be lucky sometimes, most of the time as well, but you may be wrong. And the patterns that you create are better and better as you become more and more of an expert, right? So an expert's system 1 is great, as novices system 1 is not so great. So they will often be encouraged to have good forcing strategies. So when you think this is that thing, probably just use what it's called a rational override. You need to have good forcing strategies. It's like, like use your system 1 to be a policeman. What are the 6 dangerous conditions with a chest pain? If you have someone like a new doctor coming to you, oh, this patient has chest pain, she's 80 years old and she's really hurting on her chest. My pattern recognition says like, oh, he just has myalgia. Okay, then I would encourage this learner to just stop, wait, give me 3, like a forcing strategy could be like, give me 3 tests, give me 3 diagnoses that are dangerous that we want to think about here. Okay, so maybe ACS, yes, all right, maybe aortic dissection, maybe, yeah, and so on, right? Maybe upper GI stuff that are dangerous. Okay, so then once they've done that, then okay, could you list the pre-test probabilities for me for those? I'm not saying they should be exact, but just try to tell me what is the how likely is it that it's myalgia? Maybe, okay, you think it's maybe 80%. Okay, that means that there's 20% risk of this being something else. Of those 20%, are there anything dangerous there? And if it's below 2%, like the acceptable miss rate, then it's alright. But if it's not, if it's like, or maybe 5% risk of this being time critical, okay. So you would send home this patient, and again, I'm not being judgmental or anything. It's just you would send home this patient with a 5% acceptable miss rate of this being ACS. Is that correct? That's how you think. So that's a way of like, oh, no, I wouldn't do that actually. I would not miss 1 in 20. I would not miss 1 in 10, right, of these. Okay, good. Then what do you have to do? Well, then you actually have to. So that's the way. That's a strong way of using like forcing strategies and also learning people to think by themselves and coming to these conclusions. I always like to give these what you call divergent questions. I think it's called in an EM cases podcast about it, about how to learn in the emergency department. But yeah, a way for yourself to do this, and I often do like what. It's not what I think. Like, what if it's not that? What if it's not the aortic dissection that I think it is? Or what if it's not this? What could then be? These are just I like these like forcing strategies. So, and the thing is, the system 2 will just this what's called rational override. Your ability to actually incorporate these good habits into your working life and actually using them declines with like different conditions. Like if you're in the middle of a night shift and it's late in the night shift, you are more prone to just going with what you got in system 1. If you're distracted a lot, like what you call slips, if you focus on other tasks, like if you're highly task loaded or you're quote unquote multitasking, then it's also like where you can make mistakes. So it's important, cognitive overload. So a lot of these things is important skills to actually optimize your working environment. Like in the end of your night shift, don't probably just ask a colleague about something, about a case more than you would. It's important to have that culture. It's okay to do that, especially like when you're tired or it's in the end of the night shift, when you are decision fatigued. Also, like good routines about sleep in your scheduling and so on. Focus on the task at hand, and don't like cognitively deloading is really important, right? How to like so that you don't have too many you only have bandwidth for some like so many patients, right? So a way of doing it is, for instance, as we'll talk about, flying ahead of the plane. Like once you go to a patient's room and talk with them, and then you're done with their workup, and you have a plan for them, then you ask yourself, okay, I know these three. I need to rule out these 3 diagnoses. If this test, like maybe the D-dimer and the troponin and the ECG, and maybe if that is negative, can I then send the patient home? Because you have to think about, if the tests are negative, then okay, then you have to think, right? Am I below this 2% pre-test post-test probability? And if I can say yes, then I can also tell the patient right away now that if these tests are normal, then I can send you home. Okay. But if on the other hand I see, okay, I cannot send the patient home, then I might as well admit that patient right now if there's space for it, right? Because then I'm done with him. Because if that test is positive, then I will do a CT scan. Okay, but then they will break the 4-hour boundary in the emergency department. Then I might as well just admit them. In a perfect system, it doesn't always work like that, but this is a really good skill to learn. And there's lots of other ways to cognitively deload. And so on, right? So that's the system 1 and system 2. Oftentimes, classic cross-crew would say, "Oh, system 1 is bad," or maybe not say it like that, but he would like at least Daniel Kahneman have emphasized that system 2 is less error-prone, but he tested only non-experts. And Gary Klein would say experts system 1 is great. It's even you cannot go through system 1 being an expert in a field, because you will not get anything done, because it will be too laborious. So you need to have like good habits. What I say, you need to develop these good habits when your spidey sense is tingling, when the pattern is not overlapping. You need to be able to stop and think, and then okay, what are the 3 things that I want to rule out here? Okay, and so on, right? Yeah. So what we're going into is talking about all these biases, and again, I want a more nuanced look at these biases than is usually talked about, because these biases, yes, there are something called premature closure, but also on the other hand, there's also paralysis by analysis. So all of these biases usually have a counter argument, and what is the most important here, I think, is just thinking about this balance and saying like, okay, they are highly contextual, so it depends on the context, right? So what it all is all about, like creating good habits and talking about, well, you cannot think about this forever, but it is reasonable to have a good tactic about it. So have a tactic towards like ACS or chest pain workup, right? So you have like, okay, this, and if things doesn't really fit, then yes, then you can go to system 2, and then you might have to admit the patient and so on. But you shouldn't be afraid. Oh, I don't want to do premature closure. Well, then you'll be a high risk of doing paralysis by analysis. And as Scott Wanger, as Justin Morgenstern will tell you, like this balance is important, and we do need these, like heuristics is a better way of saying it, because the biases are actually heuristics. It's rules of thumb, and most of the time they work. But we need to know when they don't work. When it's in certain contexts, like Weingart will say, like if you come into his emergency department and you're critically ill, I would rather do an error of commission than an error of omission. I would rather do than not do. I would rather treat the 95-year-old with everything I got until I'm sure. And that's an error of commission, maybe, but I'd rather do that than the error of omission. But so there's nuances to this, right? That's what I'm trying to say. Another way of saying this is that also like resuscitation of critically ill patients, that's a system 1 game, right? So great lecture by Sarah Krager on this on her homepage, where she creates this like when you have a critically ill patient and it's really like you need to make decisions now, then it's really a lot about iterative hypothesis testing. I usually say resus is like you have two lines, or like kind of. So on the one hand, you do what you call treat as you go. You go through your ABCs and you gather data, and then while you're gathering data, you kind of aligning you're picking up the jigsaw puzzle pieces and you're trying to make a pattern. And the patterns you're trying to make, you don't try to think of what it is. You're trying to think of what are the dangerous conditions that I need to treat right now. So and it doesn't have to be a condition. It could be a syndrome. Like, okay, you have wet lungs. You get the data points: wet lungs, high blood pressure, like 220, and sweating and lactate, right? And then you want the next test to be like, okay, I will put on my POCUS on the patient's chest to see if they're wet or dry. And if they're wet lungs, then you have a preliminary diagnosis of pulmonary edema. You will put on a NIV and give them nitroglycerin, right? High dose nitroglycerin. And then the blood pressure may go down, and they will may feel better. But if they don't feel better, then you have to go back, and go back to this iterative process. Okay, what is the pattern? It should work, but it's not working as I'm expecting. I need to think a lot more broadly about this. But at least I've bought myself time now. Maybe it's just a hypertensive patient with who has lung fibrosis and therefore B lines all over, like looks like wet lungs and so on. But so that's but the system 1 is the main thing in resus, and that's why we need to like what you call zero warning things, like if this happens, then do this. We need to have these mind maps of different presentations, like what we will do in this first 5 minutes on almost every condition that you can come in with. That's part of being an expert in emergency medicine. That's what we do. And you can check out Ruben Strayer's lectures on this. You can check out the podcast from Stimulus about zero warning conditions. You can check out Halo conditions by Simon Carley, his blog on those. Like, this is important stuff for us. And then if you're outside of the resus bay, then you are more likely to be more system 2 kind of thing. But both of them are needed at the same time, and they usually overlap like that. Exact. And we do need good habits here, good habits here as well in the resus, and we do need treat as you go and collect data points here. So it's they're aligning, or they're overlapping and symbiotic. So Justin Morgenstern says, discussion about cognitive biases tends to overemphasize the harms of using heuristics while ignoring their many benefits. In medical emergencies, the speed of a well-trained type 1 thinking is almost certainly more important than the accuracy of a formal analytical thought. And I would say, like, yes, so we need to teach ourselves to become expert. And I also say that the analytical will not necessarily be more accurate. It is important to acknowledge that many of the processes described are biases, as biases are really heuristics that are frequently used to efficiently and accurately arrive at a correct diagnosis. When attempting to improve our cognition, we need to be careful not to throw away the baby with the bathwater, right? So important, right? And it just sums up what I just told you. Then again, from another condition, this is from an emergency physician, right? But this is from an anthropologist about writing this great book called How Doctors Think. And she says, Catherine Montgomery here, aphorisms and maxims, however wise and conclusive they may sound, were never meant for universal application. They are situational, so what I say, they are contextual, these heuristics, that are arisen out of circumstances very like those identified in a particular case. A maxim is always case-based, right? So yeah, so also like just summarizing what I just said about like is a balance, it's context-based. And here are some great lectures on these things if you want to go beyond what I just said. There's one funny thing I want to just share with you, and this is from Croskery's Cognitive Autopsy book. I usually make the analogy of a bobsleigh. Like if you have a bobsleigh, then it's really, really important, like an Olympic bobsleigh where you go down this like really, really fast. The amount of time that you take to actually start the sleigh, that is multiplied by several points in the end. So if you're really slow in the beginning, or if you're really bad at the beginning, then you will have a terrible end, or you will have a terrible like it will add many seconds in the end. So it's worth, like my point with this analogy is, it's worth investing in the beginning. It's worth investing sitting down with the patient and actually doing a good like broad questioning and all, like data gathering. Why did you came in today? Why are you here today and not yesterday? Like, what's the reason for actually going in today? And what's the story of the patient? So on, like as I usually talk about in the communication part of these lectures. And what Croskery says is like, okay, if you start off doing, if you start off bad, like you may be getting bad information, you might be asking too specific questions, or you may not know, like then you anchor on one data point and too quickly, and then then the problem is like critical positional biases and then the problem is that they will develop what you call a snowball effect. So if you start off with one bias, there's some kind of inertia, and we all feel this. There's an inertia behind the patient. Like the patient comes in from a pre-hospital treatment, like they think it's epilepsy or they think it's a seizure, and they come in as there's a diagnostic momentum, as it's called, and it's hard to like shy away from this diagnostic momentum. And then you might, because they're ceasing, we need to go into that algorithm. And sometimes you do, sometimes you need to stop. Wait, it doesn't look like this. This is not the pattern I'm used to. It doesn't look like it. They've been ceasing for 10 minutes, but it looks weird. It's not really that. So what is it? So it's just a funny thing, like this snowball effect, and how can you like stop yourself? That's the forcing strategies and all the good habits that we talked about. That's really important. So some of the good habits are how, in general, like the over. I cannot stress this enough. We need to be able to train our system 1 and our system 2. We need to become expert at both of them, and becoming experts means that you actually, what was earlier system 2 for you is now system 1. I used to have to think about the 6 differential diagnoses of chest pain, but now they come natural for me, usually when I'm speaking with the patients, so I don't have to force myself to do that particular part. But there's lots of other things that I have to force myself to think about, right? But what is trained and trained well will become system 1 after a while. And the challenge there is to like stop and think when the patterns are not in line. So we need to be able to become experts. And how do you do that? Well, by feedback and good culture, like learn not blame culture, as we talked about, and so on. So forcing strategies, we talked about those. Fly ahead of the plane, we talked about that. Like if the test is negative, what then? Because positive tests usually are easy to, like that makes like that then it's easy. But negative tests, that's where we have to think, and we might just at least do that thinking right up front, because if you're not doing anything else, if the test is negative or positive, then you might as well not order the test. Or if the patient is going to be admitted no matter what the test says, then you might as well admit them. Or if not, then you can give them the plan so they already now know, and you can go back to your spot and then take another patient because you know what the plan is and you can tell the nurse about what the plan is. So it's a really good way of categorizing and getting cognitively deloaded with a lot of patients when you have to see a lot of patients at the same time. Checklists. Practice the known dangerous patterns before they occur, like reviewing your strategy on how to visualize different or your strategy, like mind maps of shock, or mind maps of different things. Like check out Sarah Krager's lecture on that, for instance, and the zero warning things like the zero warning checklists, or what you have to know about, right? Then you have to have a good failure culture or error culture, psychological safety, and so on, case-based reviews, feedback, and blind spots. Optimize your data collection, like compassionate care, validation, and so on, expectation management. And then I'll just go into quickly probabilistic thinking and biases. So probabilistic thinking, I have an entire lecture series on that, so you can check that out for details, but just really quickly. Patients do not have diseases; they only have a probability of disease. That's like some of the rules of thumb in probabilistic thinking is this. So they can never have 0%. They can never have 100%. They always have somewhere in between. And our diagnostic tests, they push us up or down depending on how good the tests are, and all things that we think. It's not the only tests that we think about. It's also like vital signs and other things, right? But they push the patient's probability up or down. A diagnostic test will never be taken out of context because you always need to think about the previous probability. Before ordering a test, always consider if it will change your management, if it's positive or negative. That's the fly ahead of the plane thing here. So graphically, you can show it like this. The likelihood of DVT, if you have a patient with a previous probability up here, then you probably will do a Wells score, and then Wells score might be 6 or 8, or 6 is, I think, most, can't remember. But yeah, it can be a high Wells score. And if there's a high Wells score, then you order you might order a D-dimer, you might not, because you might know that it doesn't really decrease your risk enough, but you might do a D-dimer. But then you see, okay, it's not below any threshold here. We're in 40s here. We're not in around 2%. So that's not good enough. So we need to do ultrasound, even though the negative D-dimer was coming. So you could already have done ultrasound right away as well. And they're additive, these two, right? So you cannot. They have to be different tests, right? You cannot do an X-ray and then do a CT scan. Those will be similar tests, but you can do blood sample and then you can do ultrasound, because then they will be additive. Okay, here's the diagram that I usually do. These are the conditions that we always want to think about. Let's say, and we can write this diagram at different time points. So at time 0, then all ACSs, there will be like these 6 conditions. Maybe at time 10 minutes when we have gathered our data, then it's maybe just 2 of them left, right? And the others are unlikely, and then we have to work up those 2. These are the ones that are important if you have a good test that can rule them out. And they might be important once you rule out all of these, then you can. It's as Ruben Strayer would say, it's customer service to actually treat the patient's pain and so on, but it's not our main priority, but it is something that is good to do. So we do have to know some of these and how to treat them, but from our main priority, ruling out dangerous stuff, then it's important to know the ones that can, with a good test, be ruled in, because then if that's ruled in, then there's a highest likelihood for that, then this will rule out. Given that there's the sum of all differential diagnoses are 100%, meaning that the patient has to have just one reason for their symptoms. And that's usually okay to think, but I will come back to that. Graphically, it looks like this. You have 100% of diagnoses, right? So if you put all of these together, then you'll create 100%. Time critical and likely, that's the red one up here. That's almost always not the biggest one. almost always, like, again, we are lucky, right? That's why we can send home a lot of patients and be stupidly lucky sometimes, if you don't think about what you're doing. What we want to be doing in emergency medicine is actually think about these and see if they're under the threshold or not. If they're not under the threshold, then you have to. If they're not under the threshold, then you have to work them up, right? And we had the like chest pain example here. Okay, so graphically, let's say here we have a patient with chest pain. We only know that it's 50-year-old, and before knowing too much else, we know from the previous probability studies that ACS is around 10% likely. Dissection is very not likely. How much not likely it is hard to quantify, but it's like very low, below 1%. PE is maybe 2 to 5%. And then there's the others here, MSK and so on. That's before knowing anything. That's at time 0. Let's go to time. Let's just get one data point here, okay? Just one data point. And the new data point is that, okay, the patient has paralytic chest pain. Okay, given that if they, like, we are assuming again that they only have one cause of their disease or the symptoms, then ACS, we know that the likelihood ratio for paralytic chest pain in ACS is the likelihood ratio goes, this likelihood goes down, the post-test probability line, and for PE it will go up. For other things it will go down and so on. So it will go up for some, it will go down for others, right? And we don't carry calculators in our pockets as emergency physicians. This is done in our head, but we kind of need to know the ballpark of certain symptoms and certain data points, how good they are at doing up or down, right? We don't have to do this for each like data point, but this is like graphically what we are actually in our head doing. So, but I'm saying that the sum of all of these are 100%. Let's take that point now. What if they are not? So there's something called Hickham's dictum, right? A patient can have as many diseases as he damn well pleases. That's the quote, meaning that then they don't have 100%. They have for their chest pain they have both pneumonia and pulmonary embolism, for instance. And when do we need to think about that? Well, we need to think about it when someone is frail or elderly, because they usually have lots of more diseases. If they're severely ill, right? If something is strange already, or they're really critically ill, then sometimes, yes, they oftentimes they have more than one thing, like shock conditions. Like it's not usually only that they are shocky because of hypovolemia. Usually they also have vasoplegia, and maybe you also have arrhythmia because of atrial fibrillation going 160, right? So there might be different areas that we need to target. And also, if you have someone who has been sick for a long time, then they can have several reasons for it. It's hard for our internal medicine colleagues when they have a patient that suddenly becomes worse after 15 days, right? And what is the cause? Is it part of like the treatment? Is it part of drug fever? So that's also really hard, right? So and it's called satisficing. Like the most commonly missed fracture is the second fracture, right? So sometimes they do have 2 fractures, and we have to think about the times when it might be like that. So what I usually write this out for learners, right? Okay, you came to me with a chest pain patient. What are the 6 conditions? What, like, time 0? What are, like, for your learning experience? What are the 6 conditions that we want to rule out with the patient with this condition, with chest pain? Okay, these are the 6. What do you think are the most likely? Okay, we pick out then these, the ones that are most likely. And then are there any ones that are not likely but can be ruled in? Not necessarily in chest pain. We do think about, like, if they're if they're traumatic and they hurt their chest, then yes, but otherwise no, usually. And then we have to think, okay, does this patient only have one condition, or do they have several? Do you think is this a critically ill patient? Are they elderly? Are they? Do we think that there are more than one thing going on? And if there is, then we cannot use this like up and down kind of likelihood ratio. Then all bets are off. It's either they have several conditions, we need to work them up more. And yeah. So just the last thing here. How many SAHs like subarachnoids do we want to miss? And I think the important question, as was mentioned at the Swedes conference here in 2025, is at what price do we want to avoid missing? Like how much should it cost to do scans on that many more people? So emergency medicine is this like needle in a haystack problem, right? So I always say like we need to find the needle in the haystack, but without burning the hay, right? We need to do it. We need to find the one chest pain that has a ACS, or the one headache that has a subarachnoid, but without doing CT scans on everyone else, because CT scans we know done haphazardly will create high crowding, high amount of problems for our patients with overdiagnosis and radiation harm and so on and so forth. So we don't want to burn the hay. We don't want to just find the one at all costs. So what should it cost to find the one? And what should it cost to find it with a high certainty? Like, what should the acceptable miss rate be 2%? And how much should it cost? How much is, like, if it costs, what does it cost to go from 2% to maybe 1%? Because 1% is better than 2%. But maybe at a system level, it's not, because it will cost too much. And I always we may think of these as like, oh, of course we want to go to 1%, but when we are in the really low percentages, then think of how many more patients we need to rule in. Usually, then suddenly it's much more patients that we need to do scans on. So there might be an unproportional or disproportional amount of CT scan. Maybe going from 90% to 2% might only require, I don't know, 10 CT scans, whatever, in this population. But going from the 2% to 1% might require additional 10. That's disproportional, right? Or maybe even more. So that's the questions that I often think about when we talk about this. What is the acceptable miss rate, and how much is it acceptable for us? How much should it cost? Graphically, we can show it like this. So the acceptable miss rate might be here. Okay, numbers needed to do lumbar punctures on in 250 if you do a CT scan on a thunderclap headache within 6 hours. We will miss 1 and 250, okay? But what if we move the needle a little bit? Like, what if we want to get it to 1,000, right? We want to miss less, but how many more? Like, then we have to do a lot of more lumbar punctures, a lot of more thunderclap headaches. Will a lot of more LPs will have to be done, and a lot of more post-lumbar headaches will be done. A lot of more pain will be induced. That's why usually here we do shared decision making in these cases. But yeah, different countries do differently. Denmark is not officially there yet, but might be there soon. But in Sweden we have for a long time done it like that. Okay, it depends. And on the other hand, there's a discussion. Well, should we increase the 6-hour window to maybe 12 or 24 hours? There's the Shed study in England that was recently published, right? So was by the Tarn community, and it's like, okay, should we go to 100? Well, maybe the risk wouldn't be all over here, but where do we want to? These are important questions. Like, what are we willing to make? Like, what should it cost, and what is okay? Where is an acceptable miss rate, and how much does it cost to make it even less? Yeah, just showing that there's a balance here. Finding time critical conditions benefits patient and society. Overdiagnostic and crowding and harms and so on is also a problem here, and then like costs of doing CT scans and so on opportunity cost, because someone else needs that CT scan as well. There's like acutely a problem, and there's also systematically a problem if we just do CT scans on everyone, right? So yes, how much should it cost? Okay, so take homes from this theoretical part of the lecture. Build good habits. Strategically place forcing strategies in your diagnostic path. Stop and think. Possibility checklists and list of time critical versus not, like the 2x2 table. I always do that. It's really my go-to. So you can take that and use it. Ask your colleagues prospectively if they have made a mistake, or ask your colleagues like case-based, and either if you made a mistake or if you're not unsure, if you're unsure, give them data points and see like a shadow boxing. What would you do with these data points? And you can learn something. Build your illness scripts, as we talked about, for both time critical and non-time critical conditions, especially the non-time criticals that are with a good test. You can rule stuff out and in. Systematics in particular dangerous groups. Yeah, so certain groups, certain situations are a high risk of like missing stuff. Maybe the patient with so like for instance the hip fracture patient where you or the patient that fell, that could be a stroke. Always think about ruling out strokes there, especially if they can walk and there's no problem. But even if they can walk, it's important to do a neurostatus on them. Know the concepts of Higgins dictum when the sum is not 100%, and the other one where you can use these like up and down probabilities. And a good collection of information. Sit down, compassionate care, and all. That's another lecture, but it's really important. Okay, keep your balance. Become an expert. It's hard. Again, this diagnostic thing, this is hard. You just went through 2 hours maybe of this. This is hard stuff, right? Okay, but you learn it through case-based learning. So that's the next part of this lecture. But it's always hard. Be kind and think about the retrospectoscope. That like it's always easier the day after. And it's a balance. Think about your hit rate and acceptable miss rate, right? As we talked about just recently. Like, what are we willing to make it cost for us to go 1% lower? And we can even talk with the patient about this. Like, if you really want this CT scan, I can order it for you, but I don't think it's important. I don't think it's you need to know the risks of doing this. While like now that our process probability is so low, and most patients can go home and then come back if it becomes worse, right? So it's only the ones like maybe subarachnoid who will not be able to come back if it's missed. So share decision making with the patient, especially when there's low process probability for dangerous conditions, is advisable. Yeah, and then there's different biases. Premature closure versus, for instance, premature closure versus paralysis by analysis. Biases are heuristics. We need to think of them as context-based, and we need to be acutely aware that we need to become experts, because we cannot live without system 1, but we need a good system 2 to police our system 1 thinking when the patterns are not aligning. Okay, you can choose. We haven't talked too much about this, but choose the plan that fails the best. I mean, when you have different plans, we don't have to be right. We just don't have to be wrong. We don't want to be wrong about the time critical conditions. We don't have to be right. And that's all about the retrospectoscope. Oh, they weren't right. No, but I don't want to be wrong about I don't want to miss sepsis. So I need to treat that if it's over the threshold, if it's reasonable with the data points that I have collected. Fly ahead of the plane, reduce your cognitive load, and inform your patients. If the test is negative, what then? You can, like, this is something you do tomorrow. It's really important, and one of my favorite things to tell people at my department to do, because then they can cognitive deload. I already have a plan. And when you then, if you end your shift and you have to give this patient to another doctor, then you just say, oh, here, I have the plan already. If this happens, then this. If this happens, then this. It's such a great tool. No situations where you are like bad, or like when your system 2 is drained, like this what you call rational override is drained, where you cannot rely that you're like, even if the patterns don't align, or if you're not quite sure, then during the end of your night shift, you will not like pick up on it because your system 2 is like low battery. So you need to know the conditions and spar with colleagues when you know that you're low battery. You need to have good habits and good scheduling and a good system to get a good battery, right? Get a good big battery and don't drain your battery too quickly. And when it's drained, then make it really important that you actually have things that you can do to make good decisions, even though with a low battery. So ask colleagues in that case. And then know about cognitive biases. And then like general build up a good learning culture. Become an expert. So ask for feedback. We haven't talked about that, but I've talked about it in other lectures. Ask for feedback. Blind spot bias should be like that's a problem. Like we are really good at seeing others' mistakes, but not our own. Ask someone to see your mistakes so that you can become better and coach you. Go pick someone to like do shadow boxing and have psychological safety and be vulnerable about your mistakes so that you can create vulnerability loops with your partners or with your colleagues, right? So I made this mistake. This can happen to you as well. Use what Sidney Dekker calls the new way instead of the old way of thinking. Like don't just rule out, like don't just say, oh, you're a bad apple, you need to be laid off. Ask instead, why did this great person and great doctor actually make these mistakes? Then you have much more to be learned. Even if they did make a bad mistake, then we can all do that. Okay, so then do second victim, kind of pick them up and get like this is part of what we do. And if there's a pattern, then we have to talk with them for like, do they need more education? Is it knowledge failure or is it thinking failure? Yeah. Or is it EPC? They just happen to have really shitty shifts or a shitty life besides, and they need to like pick that up. Different things, right? And then chain, and then be able to like this inertia that is behind a lot of like things, a lot of patient diagnostic journeys. Be able to stop when it's necessary and say, wait, I know the patient already has a spot in the department. I know they're drying up now, but I see that the pulse is now 30 and we need to stop. We need to think this through again. Even though everything says that this is the diagnosis that we think, something has now come up. We need to think about something else. It's really important to like be able to stop this diagnostic momentum when necessary. And it's, yeah. All right. So that's the theory part. Now we move on to the rest of this. This is only going through cases and trying to do examples of this. Okay, and the cases will be mainly around the topic of things that like looks like something but is something else. Loosely based. It could be chameleons, it could be mimics. I don't really care the difference that much. The thing is that we need to know whether we're missing something important or not. Before heading into the cases, I want to show you one thing. So every time I do a case review or we do cases in both here and in real life at my hospital, and I do education for our residents, I will always tell them that here I'm showing you, first of all, I'm picking out all the data points for you. You don't have to pick out the data points yourself. So that skill is not taught by just doing cases. So how to sit down and speak with someone is taught by filming yourself and having peer review and so on, and practicing, right? And knowing which data points counts as a dot, as Gary Klein would say, and which points don't. That's also a skill that needs to be learned. And there's different ways of doing that. But but what we're really doing here in the cases is that we're I'm giving you some data points, and we're going to practice how to weigh the different data points against each other and see which differential diagnoses are important to think about with these data points, and especially which ones should we not miss. And then we can decide whether or not they're above or below the threshold of diagnostic testing, right? So that's what these cases are really good for. They're also good for shadow boxing. So having someone go through the case prospectively and then giving you some data points and then stopping and then asking, okay, here's the case. Here's the data points up until this point, maybe at 5 minutes or 10 minutes or something. And what are you going to do now with these data points? And then you weigh in and you commit to that answer. And then you have someone, an expert, or at least someone who is considered expert in the field, to give their answer of what they would do. And then you might learn along the way like that. Another thing about these cases is that I'm showing you the case where it happens, so to speak. I'm showing you the wolf in sheep's clothing or the sheep in wolf's clothing. You don't have to sort that out between all the patients yourselves, right? Because real life is more like this. Most of what we see is actually all right. Like, it is what it is. But not rarely, but now and then it's a wolf in sheep's clothing or a sheep in wolf's clothing, right? So your senses are always heightened here when I'm showing you a case, but real life is different, and that's why real life requires these skills we're learning here today. We need to take them back, like these good habits, because that's how we might reduce the chance of missing these, or at least fail the best way if we do. So your decision making might seem obvious in these cases, but it's not in real life, and that's why we need to practice this. And this is just, as I said, one way of practicing an aspect of our work. There are other aspects that we also need to practice to become good at these things. Okay. First case. At the orthopedic part of the emergency department, you see a 49-year-old carpenter who has slept badly and woken up with a weak thumb on his right hand. He has, and I do the Maples here, medication allergies, his previous history, leisure, like social stuff, like can you walk, can you talk, what you work with, ethanol and consumption of like beer and also drugs, and then smoking. And then I usually do a plus as well. I didn't do it here, but usually I do a plus, Maples plus, meaning that what about hereditary conditions? What about vaccines? What about exposure to like travel history and so on, if relevant. So it's like, yeah. So before we begin the exam, where do you think the lesion is? So when we have someone presenting with a weakness, and now in these cases I'll both try to go through the case and teach you something like that, teach you or try to teach some of these like nuances and maybe some mimics and chameleons, but also how to think. And this is what like knowledge, the knowledge part of why we miss things. I need to show you the knowledge that you need to have. So what we want is, where's when we have a motor deficit or a sensory deficit, we will ask where is the lesion, and then we will ask what is the lesion. And I've done entire videos on this, so I won't go into too much detail. But in general, when we do our OPQRST, then where is the lesion has to do with the position of their symptoms and the quality of their symptoms as well, actually. And then what is the lesion? It has to do with how fast it developed. So that this is usually the timing, and also somewhat about the quality of the symptoms, whether it's positive or negative symptoms, and how the temporal aspects is. Like, did it come up and then it went down and then came again and then it went down and then came up again? And is like, how many minutes is it? Is it everything at once, or is it just one thing and then comes another thing? Like, is first the hand, then the arm, then the so these are really important things that we need to know when there's a motor lesion. Oh, sorry, where there's someone presenting with weakness that might be a motor lesion or some other lesion. Then I always like to this is a hardware problem, right? If you're speaking in functional neurology terms. So I always want to add this: is there a lesion? Because like things can present both like a mimic or a chameleon, like they can present with a hip fracture and have a weak leg for that reason. But there's no stroke, but it seems like a stroke because they're weak in their leg, they can't walk. So that would be a stroke mimic without any neurological lesion, right? It can also be something that it can be a medical cause for a neurological lesion, like something medical has an influence on the nerve action potential or something like that. And that will also that would be a true lesion. For instance, like hypokalemia, myelopathy would be a true lesion actually. Whereas PMR, like polymyalgia rheumatica, which also leads to somewhat like a myopathy kind of can like lead to like a myopathy kind of condition and presentation. That is more like there is no lesion. It's not a nervous system problem. It's just a pain problem. So yeah. So again, this is a bit academic. It's more like, but is there a neurological reason or not? It's good to just ask: is there a medical or functional reason for some of these symptoms? It could also be with our patient with thumb weakness here. Really rarely, maybe, but could it be like they have a arterial occlusion and therefore they cannot move their thumb? That could also be where there might be some nerve damage along the way there, but it could also be pain related and or either or. But is there a lesion? The thing is that the functional neurological thing is really, really important also to think about. And I've gone into details on that in different lectures. It's really important that we know about functional neurological diseases because it's one of those conditions, because it's one of those conditions where you can rule in by ruling out and make, because we have what you call positive diagnostics in neurology. With functional neurology, you always have to ask a neurologist as well, but then the nervous system acts in such a way that is predictable with the wiring, with the hardware problems, so that if it doesn't really live up to that, then we can kind of examine the nervous system, and if it doesn't act like it should when there's a lesion, then it could be a functional neurological condition. And it's very common, and it's not something that they themselves induce. It's something that we have to teach them how to be aware of, and it's mostly a dissociative thing. It's not a factitious disorder as it's called. It's really rare that they just do it because they want to gain something from it by, like they're cheating, sort of. That's a bad standpoint to think of when you're going into the examination with the patient. Think that it's always something that they don't know about, because you'll be right most of the time. Okay. So when we have this information is what kind of informs our pretest probability. Then it's like, can I confirm my hypothesis through examination? So then we go into the tests to see whether it's likely or unlikely, and much of the likelihood ratios here lie in how we understand the hardware. So we need to have some neuroanatomy understanding, and I'll go through that in a little in I think the next couple of slides. So the first slide here this is about what is the lesion. This is the timing of the lesion and how. This is from Berkowitz's book that I showed you in the beginning about. So you have vascular lesion, like something that occurs within seconds is usually seizure or vascular lesions. Migraine is usually a bit more over minutes. Trauma, of course. Metabolic, yes, hypoglycemia usually quite also over minutes, maybe more so than suddenly, unless they took insulin just right away. Right, and toxins also over minutes maybe, but seconds is usually vascular or seizure. Then you have the more like over hours, days. Usually that's infection. And really importantly, we will talk about upper motor neuron syndrome. When you have a lesion, central or peripheral, you will develop either the upper motor neuron lesion or the lower motor neuron lesion syndrome. And but the upper motor neuron lesion syndrome takes a few days or at least some hours, depending on the condition, to develop. So a patient with a stroke will not have a hyperreflexia or a spasm or a like a increased tonus right away. They will be flaccid and not have any reflexes in the weak arm or limb. So when the patient presents several weeks or days after, then you can begin to use these reflexes, and you can check for tone as well to see that they actually have developed an upper motor neuron syndrome. And that's what we use in Guillain-Barré syndromes, for instance. It's something that you can use also in the myelitis cases as well. There are some what do you call? There are some anomalies to that rule. So if you have a seizure, then they will have a Babinski's reflex, which is an upper motor neuron thing, right after, oftentimes at least. And some intoxications can have clonus right away as well. I'm not sure if it's the same mechanism though with these, but some of these conditions might have. But strokes, like vascular events, will not have it right away. Seizures will have it sometimes, and it will pass within a few minutes to hours. So it's right away. Then they will have a Babinski, and then they will go away again. Migraine will not have it, and so on. Then you have the subacute over weeks to months, and here you have some of the still inflammation, infection, sometimes atypical infections, and like subdural hematomas, vascular malformations, and then you have these neurodegenerative disorders. I don't agree that these always are over years. You can have these acute dementia conditions like Creutzfeldt-Jakob disease and others. Like there's a long list of these acute that you can read on in Conciella's book about like the emergent, the hastily developing dementia-like conditions. These are mimics as well, but they can really. Here you have to think about these things as well. Okay. So that's like what is the lesion, and that's all about the timing and the temporal aspect. Then there's where is the lesion. So you can have your cerebral part. So this is just a map over the nervous system. You have a brain, brainstem, the spine, or the cord, right? And then you have the peripheral nerves, and then the muscle and the muscle nerve junction, right? And each and every, like when I usually teach this model, I would say that there's different levels to this. So this is level 1. This is the gestalt, like and the most common symptoms for this, where we have to pick it up. Then there's level 2 and level 3 and level 5 and so on, like where you go more into details. For instance, with stroke syndromes, like level 2 might be subcortical and cortical. What are the differences? Because that's important for us as well to know, because is this a patient that needs endovascular therapy, endovascular treatment for stroke, or is it not? That's become more and more important to know whether it's like something that has a higher risk of being like a proximal artery or a distal artery, right? So that might be number 2. But most of these syndromes, for emergency physicians, we actually don't only need to have the level 1, and then we can always ask neurology. But most of the time, we can actually we can do the hypothesis ourselves, and then you can always move on and either ask or you can do the case yourself. And I tell this like this because oftentimes when we are taught neurology, it's this, I usually call it the bottomless pit of neuroanatomy. It's fascinating, but it's not clinically relevant most of the time. So we need to like teach it the right way in what is actually needed. And I think this is the right way. So then we go to the brainstem, which is characterized by these crossed findings. So ipsilateral in the head and contralateral in the body. If you want to move, that's just 1.0. If you want to move to 2.0, then you have to know the rule of 4, which I haven't made a video about it yet, but I might do at one point. But in general, you can just check up Gates in Life in the Fast Lane rule of 4, and in short, it's like you have two syndromes. You have the lateral syndrome and you have the medial syndrome. And the medial syndrome is usually quite easy to find because they usually present with weakness. It's the 4 M's. And you have the 4S syndrome with the lateral syndrome. That's where it's harder. That's the Wallenberg syndrome, for instance. And there's another thing about the good thing about the brainstem to know about is that Eric Driver usually calls it a hourglass. So you have the brain up here. All the nerves are distributed all over the brain, right? And then all on down here, all the nerves are out, like distributed all the way out here. But in the middle here, it's quite compact, also all the way down the spine. So if you get a lesion here, just a small lesion, then you have a lot of weakness or sensory. You have a lot of findings, right? Because there's only so much space. A big just a small lesion here would give you a lot of symptoms, and you can use that oftentimes because sometimes they only present with a small thing, and if you think the most likely location is the brainstem, then it's really unlikely. If they only have like a few symptoms, but it points to the brainstem. The only there is one thing that is outside of that rule, and that is if you have MS, for instance, neuroinflammation diseases, especially MS, can do like pointed lesions. So you can have INO, for instance, which is really common in MS presentations. INO is internuclear ophthalmoplegia, where you have the eye, when you look to one side, then you cannot adduct the eyes, the left eye, and you will have a nystagmus on the right eye. So it's like, so they can get pointed, like small micro lesions, and only give a few symptoms, even though they have brainstem involvement. But most people, if you have a bleed there, you will have lots and lots of symptoms. Okay. Then you have your spinal cord, and the spinal cord is usually you usually present with a triad of one, at least one of those symptoms that I'll tell you. Either you have a sensory level, meaning that you feel like there's a belt usually around you. It can be a hemi sensory level. Like I had one patient telling me that they only have a lesion here, and then they only had like they felt half their abdomen. And that was that the person had MS lesions, right? It was really punctated, like small micro lesions in her spinal cord. But so that's the sensory level. Then you can have bilateral symptoms, and that's also a hallmark for myelitis, because they will have paraparesis or tetraplegic. They will have both sides involved in the same time, and that's a problem when you test the reflexes. Usually they will be similar, the same, like, but they can be. So you have to be able to. You cannot always compare with the other side, and then they will have urinary or anal problems, right? So those are some of the symptoms that you will. And then you can subdivide these. Level 2.0 here is you have the central cord syndrome, you have the anterior cord syndrome, and so on and so forth. I've gone through that in another lecture if you want to check that out. Then you have these peripheral ones, and these can be quite tricky, I think, and not all neurologists know about them. It's more like an orthopedic thing to know about them, because usually that's their, like, traumatic lesions are common here. But you have your polyneuropathies, which are symmetrical, and these the neurologists do know about. So polyneuropathies where you have symmetrical, either sensory or motor deficits. The most common is sensory, like kidney failure, like kidney failure slash diabetes, and then alcohol. Those are like maybe 60 or 70%. Then cancer drugs can also give polyneuropathy, and alcohol use can also. Sometimes if it's really severe, then you also get like the wraparound nerves to the stomach, like in the middle of the stomach. You will have a sensory deficit as well. And then there's small differences. If you have a plexus injury on a root injury, then we have the entire root, as opposed to the distal part. If you have, like, now we're talking mononeuropathies. Okay. Yeah, you can read this as well yourself. The difficulty here is to know which nerves goes where, so to speak. So I will show you the rules in a little while, but it's hard to remember. I always have to look it up. Then you have your this down here should say root lesions, not the red lesions. Then you have your muscular junction and muscle, and these are known for, if you consider those, these are proximal muscles. Apparently the big muscles, usually the ones that goes first here, and those are the shoulder, the deltoids, and so on. So they will have proximal, but not so much distal weakness, and they will usually they will not have any sensory deficits. It's mainly motor. Then you have then to distinguish whether it's a NMJ, like a neuromuscular junction, like myasthenia gravis, or a myopathy. Usually, the hallmark of myasthenia gravis or Lambert-Eaton syndrome, as well as the other one. The other one. Or Eaton-Lambert, is that you can have usually these will be fatigable. Okay, so they will have fatigue. So once they've done the thing 20 times, they will not be able to do it, and then it'll be better after a little while, maybe after ice packs as well. Okay, so that's the weakness, kind of where is the lesion. And then you, like, the peripheral nerves here, like if you talk about myotomes, then usually you can do this, like this sign here. Then the median nerve is, if you do a OK sign with your index finger and your thumb, the spreading of these fingers is the ulnar nerve, and then you have your radial nerve where you're extending your wrist. You can do this, especially in children. If they can do this, and there are other signs as well. It can also be rock, paper, scissors, or stuff like that. Then they're good. Then they don't have any motor deficit in those nerves. Then you have the motor deficits of the leg, and usually I say like L5. That is where you stand on your heels, meaning that's the Achilles, and S1 is where sorry it's like L5 is, again, I have to repeat this for myself, even though I've taught about it a long time. So I always find these quite hard, actually, and always have to look them up. But L5, that is what, if you stand on your heels, then you're testing L5, the L5 myotome, because that's where you look like an L. And if you stand on your toes, then you're testing the S1, because that's where you kind of look like an S when you stand on your toes. And then it's important to know whether, if you have a drop foot, you can read this yourself, but if you have a drop foot, then it's the E version that is important. The inversion that is important, because to distinguish between an L5 lesion and a local peroneal nerve injury. Then we talk about the dermatomes, and if you want to know more about the myotomes, there's there's different in the Geraint Fuller book. They have this upside down man that I've shown in another lecture, where you can see which kind of like it goes with a rhyme or with a small mnemonic. I feel like like 3, 4, close the door, 5, 6, pick up sticks. It depends. Like it shows you what like 5, 6 is like 3, 4 is like C, 3, 4 is like close the door. That's where you have your triceps and so on. So you can like remember like that as well. You can look that up in another lecture of mine. Then you have the dermatomes, and if these like there's a lot of overlap, but according to EM cases, this is a good rule. Median on the on the index finger on the volar side, ulnar is on the volar side of the ulnar, the volar side of the little finger, and then here is the radial. If you have for testing dermatomes, if you want to test the roots, then think of your middle finger as the C7 on, and then you have 2 roots on both sides. So C7, and it's like C5, sorry, C6, C5, and on the other side is like C8, CH1. On your legs, you can check your knee. This is from it's the this is from the education. I can't remember this where it comes from, but this rule is like L5, L3, L4, L5, medial, middle, and lateral aspects of your knee, and then the pinky is S1. Okay, so then you have the dermatomes as well. Okay, so for this carpenter who has a thumb weakness, the most likely would be a PNS, a peripheral nerve lesion here, right? Because they have some, it's just a peripheral nerve lesion. It could also be an atypical stroke, what you call a homunculus stroke. That would be quite rare. Or it can be no lesion. It might be a fracture, it might be a thrombus, something like that. But we need more information, so we're going to examine him. So when we examine this patient, there's normal pulses and it's not pale or anything, so like vascular things are unlikely. He cannot do any movements. He has intact sensory distribution in his thumb, but he cannot do any movements with his thumb. So the piece of information that we need to know here is that the thumb is innervated motor-wise with all 3 nerves, so median, ulnar, and radial. So how would that work out, right? How, if you have someone who has a totally weak thumb in all directions, if it should be a peripheral reason, then we would expect that that there are some sensory losses as well. We would probably expect that usually if you have so many lesions, usually it will be more proximal on your arm, and if it was more proximal on your arm, where all these nerves were hit, then it should have been then you would have more deficits if it's more proximal on the nerves. So it doesn't really make sense, this. So this understanding and this key knowledge makes this thing be more likely that it's a homunculus stroke. So suddenly, even though the pretest probability was quite low to begin with for homunculus stroke because it's rare, it suddenly went up. So the homunculus here, you can see the thumb is quite big, and homunculus strokes is only it has to be a quite big thing. So the take home here is that if you have a big part of your homunculus, that could be a foot, or it could probably be a thumb or an entire hand, but it should not be part of your back. Might be part of your face though. Then you can have a homunculus stroke. So it's an entire unit, for instance, a foot that cannot move in any directions. Then you have to think of homunculus strokes. It cannot be attributed to only peripheral nerves. Yeah. Okay, and that's the take home here. We need to know about this. Where is the lesion? What is the lesion? Is there a lesion? And can I confirm my hypothesis through the examination of the patients? And then we need to know about this homunculus stroke concept, that these can also be. Okay, Okay, so another case here. A 20-year-old male, previously healthy, who woke up after a dorm party and he cannot move his arms and legs. He was like, he, um, they thought it might have become, they thought it was just like an intoxication. But what had happened is he came in as like intoxication and maybe mild trauma because he fell out of bed and couldn't really come up, get up. So he called like 911 uh, from his floor, and this is a young man who's fully functional, right? So it was kind of odd. Um, so so his Maples was like he had migraine with aura, and he was who was student who drank on the weekends and so on, but no drugs. So I went to him after a couple of hours. He'd been in a couple of hours in the ward by then, and he was lying in bed, touching. He was moving, not touching. This is also AI. But he was moving his distal extremities spontaneous, but not the proximal ones. His A was free, saturation was like this, calm breathing. RH is not, it was respiratory frequency. Blood pressure is 120 and pulse is 60. GCS of 15, normal blood sugar. All his cranial nerves were normal, no Horner's phenomenon or anything, but motor wise, he was proximally weak. Distally, he was stronger, but not perfectly strong. His coordination was hard to assess because when you're weak in your arm, it's hard to assess your coordination. Yeah, he was afraid prone. So what do you think? Where is the lesion? So if we, oh yeah, before we go to where's the lesion, he had an ECG taken as part of like the general workup because they thought he might have syncopized or something like that. So this is like narrow QRSs, sinus rhythm, frequency of let's see 300 divided by 1, 2, 3, almost 4. So it's like 75. That looks all right with 80 here. And he does have a has the normal variant of a T negativization in lead 3, but other than that, it looks good. And then other things like you have a little bit of a U wave here actually. And that's kind of so you have a prolonged Q to C because of that U wave. All right, so what is a lesion? It came on quite suddenly. We don't know what happened during the night. It could be here. It doesn't really tell us much. At least we cannot use the upper motor neuron syndrome kind of thing here. That's that much we do know. And where is it in the nervous system then? So proximally weak, no sensory deficits. That looks like this. All right, it looks like a myopathy. And so we wanted to like myopathy usually doesn't develop with age, like it usually doesn't develop like suddenly. There's a few sudden myopathies, and one of them is potassium or electrolytes disturbances. It could also be if you took statins, but mainly they are usually developed over time. Hereditary ones develop over time. So what could this be? Well, it could be a myopathy. Could it be atypical Guillain-Barré? It's definitely something that we always need to think about with when we have para symptoms. Could it be a man in barrel syndrome, like myelitis? It's like it's a central cord thing. Well, maybe the homunculus goes into the central cord as well, like down the spine, and the arms are in the middle of like towards the central canal. So if you do get a central syringomyelia, then the central cord will explode, right, or become bigger, expand, and then the arms will be involved, and that's one of the differential diagnoses of man in barrel. So it could be that it's really rare, but it could be like you can get that like if you think of the central cord in the spinal cord as a straw. If you do a hyperextension of your neck, then sometimes you can get damage to those cells in the middle because like the straw in the middle will kink. It might. That's what I wasn't explained the pathophysiology about this. It might not be totally true, but it's a good way of thinking of it. And then you can kind of, with a hyperextension trauma, it was quite a mild trauma, and he like chronological wise, it doesn't really make sense if he fell out of bed. But he had the neural deficits already. So the preter's probability is not too high here, but he doesn't have any cranial nerve deficits. It's only motor. It does look mostly like myopathy. So we took electrolytes, and then we would ask neurology for advice here. But it turned out that the potassium was quite low. It was 2.2. And so we did give him telemetry because the potassium below 2.5, and we substituted him with maximally 10 to 20 millimoles per hour and plus orally, and then he actually became quite good after a short while at magnesium as well. And it's turned out down the road that he turned out to have familial hypokalemia, and that's why the U wave from the ECG was the hypokalemia as well. So yeah, myopathy, consider case 2. This was a 40-year-old previously healthy man who presented with bradycardia, dizziness, and syncope. He came in as a critically ill patient with a full personnel on the site in the resus case, right? So he has his ECG pre-hospitality was sinus rhythm with narrow QRS complex and nothing else besides extrasystoles, supraventricular extrasystoles by Gemini. All right, so. And he had some history of having some symptoms that could not totally be explained by just neural lesions. But other than that, he was working and he was feeling well otherwise. He was a bit cold when he came in, but not bradycardic anymore. He was a bit tender. He had been vomiting as well. He looked quite bad. He was like pale and sweating and nauseated. He seems like to be hyperventilating as well, but he also had a lactate. His ECG was unchanged. His focus were normal, and I was kind of worried about this guy because he doesn't look good. I'm not sure what it is. So you can do this 2x2 matrix where he's like, do I know what it is or don't I know what it is? And does he look bad or doesn't he look bad? He looked bad, and I didn't know what it is. So that's always a problem, right? That's where he's, we need to do something, but. We got a little bit more history. He said that he woke up at the same time as usual, and then he was dizzy. So that's his main symptom apparently. He was dizzy, and then a lot of other stuff happened, and it kind of went into the background, this dizziness. But he was dizzy. He did say that. And when he came to work, he would get these cold sweats, and then he would feel uncomfortable, and he would pass out with a prodrome, right? So he had a prodromal syncope, and he did that twice because he tried to stand up and he was vomiting as well. But he would come to quite fast afterwards. So the syncope was not the syncope alone was not too disturbing or not too worrisome because it was a prodrome, but the syncope along with him being pale and looking in a bad way. Is this bleeding? Is this something there's lots and lots of differentials here, right? And you really want to get this patient worked up quite fast. So because there was dizziness and he just feel dizzy, I just checked his pupils really quickly and for nystagmus, and it did actually have nystagmus. This patient, he had unidirectional nystagmus going to the right. So I did he had no autofocal symptoms. So I did a head impulse test on him, and he had a catch-up. Okay, when you did the head impulse test on to the left, he didn't have any skew, he didn't have any hearing loss, and he could stand and sit by himself, even though he had to be encouraged to do so. He could do it. So what's the diagnosis, you think? He probably, from these data points, have vestibular neuritis. And it could be interpreted that this is a vagal thing, that he radiated down, was vagal, because now he's doing fine. His ECG doesn't show anything, and he syncopized twice, also a vagal response probably. What is a bit worrisome though is when you have the undifferentiated, you want dizziness. The patient who has dizziness plus, like plus syncope, is this a subarachnoid? But he didn't have any headache. Is this arrhythmia? Could be. So we did monitor him on telemetry, and gave him steroids for potential vestibular neuritis. I know it's controversial, but that's what we did, and he did become better on that actually. So yeah, so we used the tactic that I have shown in another video, and it showed we were quite confident that this was not anything bad. After observation period, he became a little better. He got some fluids, and we got his dizziness a little bit down, and then we came to the conclusion that he had a peripheral Hinz syndrome, right? So that would be vestibular neuritis. And I had a few cases of these where they become very vagal from their experience because it's so uncomfortable. So it's always in the back of our minds: is this vagal or is it something else? So what we did here is there's a long differential on this guy, but because I could rule with certainty, I could rule in peripheral cause. Then the more dangerous stuff became much less likely because the sum of all things are all differentials here are 100%. We would assume, right? So ruling in by ruling out. Here's a good reason why we need to know the benign causes that can be ruled in a good way. Okay. Case 3. An 86-year-old woman who was admitted as a stroke, no noise, as also AI, suddenly could not stand on her feet, and she was the healthy one living with her more sick partner. She had a minor stroke 10 years ago. She was a little bit on the heavy side. Arthritis, she had gout and hypertension. She did have a glass of wine now and then, but not much, and she never smoked. When she came in, she was kind of like, she was unaffected mostly, but she was kind of these like vegetative symptoms. Always like, she was closing her eyes and she didn't really want to talk with us. She was there, but not really. She was like almost dissociative. So she was, but she didn't seem affected. Like she was like la belle indifference. Like what's it called? Like where you're not bothered by your symptoms, sort of like, yeah. She was not fried AI again. It was a free A. On the D, the B and C were okay, and then D, she was like, yeah, E3, V4, M6. She wasn't totally oriented, and she was like this, looking like not looking, and like being comfortable in her state of not caring about this. It was her husband who had called in. She had equal motor and sensory function. She didn't have a definite ataxia when you tested the hands and feet, or the knees and the finger test, but she could not walk unassisted. She could not walk unassisted. She fell down when we tried to put her up. And she has some unspecific, non-specific oscillating eye movements, no nystagmus, and everything else was normal. So, what do we do with this patient? Like, suddenly she cannot stand and walk. She'd been cooking, and then suddenly no loss of consciousness, but suddenly both her legs gave away. She couldn't stand up. She called 911. So here's a piece of information that you need to know. If you have a patient who is dizzy or cannot walk, then if they're persistently dizzy or persistently cannot walk, then if they don't have, then they can either have like acute vestibular symptom with nystagmus, importantly. But if they are constantly dizzy and do not have nystagmus, then you have to test them for acute imbalance syndrome before letting them go. They have to be able to stand and sit unassisted. And if they cannot do that, then they will have a grade 2 or 3 ataxia. according to the grade 3 paper by Edlow, and then they will actually be quite high risk for stroke. So a lot of these will have a stroke, it turns out, if they suddenly, and it's called the acute imbalance syndrome. And this is from the article by Machner. Okay, so she could also have a top of the basilar stroke, this woman. It's kind of like these, like if you do have a stroke in your basal artery, it's the few patients I've seen with that syndrome is usually it's exactly like I've just described. They have usually no focal deficits, but they're kind of like they're decreased in their GCS, but they're comfortable with it. They're kind of, it's hard to explain, right? But it's and when so could it be a medical cause? Yeah, there could be several medical causes for this. Geriatric compensation, could be alcohol intoxicated, so on and so forth. So the CT, we went on with the CT angiography, and they had no large thrombus. So should we do TPA on her? Yes or no? So I've gone through the literature on CPA before. I don't want to do it again here, but and smarter people have done that as well. There's a list of references here, and especially for patients with the NIHSS score of below 5. I've done this video where I go through the literature. This is the video where I go through it. And in short, it's just there's only 2 positive studies on thrombolysis and stroke. There's 13 RCTs, and most of them are neutral or negative. And these 2 green ones, the NINS2 and the ECAS3, they've both been reanalyzed and have been found to be neutral as well. So it depends, right? And there's a lot of arguments. This is really where we can go into neurology versus emergency medicine as in evidence-based medicine. But all right, that's a discussion for another time. But in general, just the essence here is thrombolysis is not a it's like if you have a thrombolysis is not we're not sure that it actually works. And if it works, it may work on a subpopulation that we cannot really necessarily find always, even with the new scanning techniques. And yeah, so that's the issue with thrombolysis, right? And then that's for the bigger strokes. Like for the smaller strokes, if you have a NIHSS, maybe I have a stroke now, like NIHSS below 5, then there are some studies like the PRISM studies that is actually what I'm going through here in this video, will show that there's a high likelihood of death, or they did like RCT where they did acetylsalicylic salicylic acid versus thrombolysis, and they had to stop it early because of high amount of harms in the TPA group, and no benefits. And they will tell you that they didn't stop it before they should, for some other reason. But in general, if you have an NIHSS below 5, which this woman has in this case, then it's problematic to do a then it's problematic with thrombolysis according to the literature, because the harms doesn't outweigh the benefit. The benefits doesn't outweigh the harms. And if this woman has any stroke anywhere, then it's a lesion in the back of her head, right? It's the posterior lesion. And besides the basilar strokes, like cerebellar lesions and the brainstem lesions with few symptoms usually do really well without thrombolysis. They have they can be rehabilitated quite good, and almost be normal functioning after a while. So there's not a lot to win by thrombolysis, and there's a lot to lose as well. So it's an argument, right? And it's the same with the monosymptomatic dizzy patients who rule in for hints with stroke, right? They should they be thrombolized? You can check out Edlow's EMCrit video, EMCrit podcast recently. Like it's like 300 and maybe 80, something like that. And episode 380, and then they'll tell you it's really controversial, but the answer is usually no, they should not be thrombolized because we don't think they have benefit to harm, a good benefit to harm ratio. First 10 EM, Justin Morgenstern will say this. There are some risks that we are certain about. About 1 in 12 patients will have severe bleeding resulting in worse neurological outcome with thrombolysis, right? It depends on when and how big the stroke is and so on. There are some factors, but in average, around 1 in 12. Despite that risk, in the best case scenario, about 1 in 10 people will, given the drug early, will have noticeable improvement in their function after 3 months. How much is usually an MRS score on average about 1. And it's important to go from 3 to 2 on an MRS, but is it worth, it's a nuanced discussion, right? All right. What I didn't do in this case, but I encourage everyone to do with like these acute imbalance syndromes and others as well, where you cannot, like, we're not quite sure, is to take a serum alcohol or make them blow like an alcometer. Because in this case, this patient had, again, AI, sorry, but had 2.5 promille. And that was the reason why this patient had. I did order the blood test, but it came out. It came after like 3 or 4 hours. There was a problem with the laboratory at that point. But that's a good, like, also ruling in by ruling out thing, because if they had that, of course they could be drinking, but that the drinking could explain it. And with the NIHSS score of below 5, then yeah, not thrombolysis, just see where it goes, right? Here I'll present the stroke mimics, the 5M3P migraine. Migraine, though, usually develops gradually, whereas strokes is suddenly. And migraine with aura should go away within 30 minutes. Each aura symptom can maximally last for 30 minutes, and the migraine headache for maximally of 72 hours. There are atypical aura durations and atypical migraine presentations, such as motor deficits, and sometimes if you have something presenting like a migraine, but it's with motor deficits, you do need to talk with a neurologist, unless it's known for the patient to have these. Of course, meningoencephalitis and infections such as sepsis, metabolic like hypoglycemia or alcohol or other electrolyte disturbances, mass effects like such as brain tumor, abscess, subdural hematoma, multiple sclerosis. Usually that doesn't happen right away. It's usually something it's been going on for some days or hours before they come. Post-ictal, like they have TOTS paresis after an epileptic seizure. Psychiatric, the FND is really important as well. And then the peripheral ones, like Bell's palsy, where you have to look at the eyes and the spontaneous movement of the eyes of the patients to see that they have a Bell's palsy or a peripheral as opposed to a central. Also, the forehead rule also works, but it's usually hard in the beginning of the symptom in the beginning of the patient's symptom journey, because it might not be fully developed. And so it's easier to just look at their spontaneous eye movements. When you're talking with them, you'll notice that they blink less on one side. Hip fractures, we talked about hip fracture, and ear diseases like vestibular neuritis and when we talked about Hint's test, how to. So these are some of the mimics. This is from Eric Driver's article in the Swedish Läkartidningen. Around 25 of these. Around 25% of all strokes have mimics, and 5% of them are thrombolized. So I guess one of the things to know is that if you do end up thrombolizing a mimic, they have a much lower risk of bleeding than if it was a stroke. But it's not 0, but it's like 1 in 500, 1 in 1,000, something like that. You have the absolute contraindications that you always have to go through, though, and aortic dissection, like you can have dissections like if you have chest pain and neurological deficits, then you would think about a dissection, right? But bacterial endocarditis is one of those things that really you need to think about as well. I have seen one being thrombolized and they had really bad outcome. These septic emboli will bleed, and they will usually have severe lesions as well. So you need to listen if they have fever and you're listening to the heart and they have a new murmur, then you have to think about that, especially in drug addicts. And the relative contraindications, the thing about NIHSS below 5, if it's invalidating symptoms, then they usually, at my place, will thrombolyze. So it depends. It depends on the case-by-case basis. But if you want to know the evidence, you can check out the video I just showed you. Take home from case 3 here is that no stroke mimics. TBA for stroke. Oh, this is really word salad. Sorry. TPA for stroke is something that's controversial, and you need to know, locally on the site beforehand. How are you going to tell the patient that they the benefits and the harms, and know the contraindications and so on. And if the CT is negative, you always the CT we do in strokes only to rule out bleeding, right? And also maybe to rule in big proximal lesions where you have to do go to thrombectomy. But if the CT is normal, then you have to treat it as a stroke, right? And that would be thrombolysis in this case, potentially. So you have to know that. Okay, case 4A. This was an 83-year-old woman with known atrial fibrillation, and she was admitted also for stroke, or suspected stroke. Found on the floor, last seen normal 12 hours ago. She had these diseases in her background, and she doesn't move her right side, and she had a bit of a high blood pressure, and it was she was low in GCS. And when you looked at her eyes, she was gazing towards the right, and her eyes actually, it was not E1, it was more like E4 because she had open eyes, and they were pointing to she had conjugated gaze deviation to the right. So what could this be? Well, intracranial catastrophe, yes. Metabolic cause, of course, it can be. And then status EP. Why status EP? Well, the thing is, what we did was we gave her diazepam. And why is that? And then we called the anesthesia to intubate and so on. And we did a CT angiography after that. But why did we want to do that before going just to CT? Because it turned out she had a big bleed. Well, then this is the knowledge thing here. If you look at this, if you have a conjugated gaze deviation towards the right, and you have a weakness in the left arm, then as the rule follows, you will look towards your big stroke. So that's what this guy is doing. He's looking towards his big stroke. Fits. Our patient was more like this, or so they were not shaking, but they were weak in this side, and they were also looking to the same side as their weakness. And if they had a stroke, they should be up here, like on the right side. But they didn't. They didn't. So this is, and that's the take home. This is epilepsy, right? This is a seizure. The seizure will push away the eyes, so to speak, towards the other side. So what our patient actually had was there was a bleed, but then the bleed caused a seizure. So that once we gave her the drugs, this like the diazepam, her eyes turned to the other side, and her eyes closed as well. It might have been because she was sedated. It might be because that the seizure was over. And it's always hard to see. Well, do they have non-convulsive so EEG is in order once they've been intubated and so on. The last one is just this one is the exception from the rule. So the rule being, if it's a stroke, you look towards your big stroke. If it's epilepsy, you look away from the epilepsy area. So, but this is the anomaly here. So when you have a pontine stroke, then you will look away from your big stroke as well. But they usually don't develop epilepsy. It has to be cortical irritation usually to become epileptic. Yeah, strokes and unconsciousness. You can only be unconscious by either the battery of your, like the arrest system is not working, or both light bulbs are out. Right. So either you have a arrest stroke, which is a tubular stroke, or you have a major stroke that is affecting both light bulbs, which would be the rare Pécheron artery, where you have one artery, when you have a stroke in one artery, but it goes to both sides. It's an anomaly. Pécheron, it's called, Pécheron, I think. And but you can also have a stroke on day 2 or 3 where they're compressing the other side, and this also happens in the cerebellar strokes. So that's something to look out for. Even though they do well otherwise, they can develop like malignant stroke where they press on the other side of the brain so that both light bulbs go out. And then you can have stroke with with the status epilepticus, right? And if you have a status epilepticus, you're shaking both hands, then both light bulbs should be out. So if you have if you have an FND, a functional neurological disease, or and it's if you have functional seizures, then it's important to take their hand and see if they can have movement voluntarily, because if they're seizing in both arms at the same time and they're not, like, if they're unconscious, then both light bulbs should be out. They should not be able to have any voluntary movements. So if you can take their hand, talk with them, and then they get voluntary movements along with like a pretest probability, like they've been seizing for more than just 3 minutes, but because most seizures they end within 3 minutes, they don't have any tongue bites, lateral tongue bites. The seizing is the semiology is waxing and waning. Maybe it's not this crescendo decrescendo thing. The eye movements doesn't look like if the picture doesn't fit, then you can try to take their hands and then talk gently with them. I learned that from a epileptologist, and the theory behind it is like this: they should not be able to do any voluntary movements, even if they just catch your eye, like you catch their eyes, looking at you voluntarily. Any voluntary movement, it cannot happen when you have a bilateral involvement, right? Because you're away. That doesn't mean, this is important, it doesn't mean that you cannot have complex seizures, right? You can have seizures where you're moving, where you're running, where you're shouting, but it's usually quite stereotypical. It's quite like, you can open doors even sometimes. You can read the or watch Susan O'Sullivan's lectures on this, on her books on this. But it's really, you can have that, but it's quite stereotypical, not voluntarily. So yeah, that's what I wanted to say with this figure as well. Okay, so the unconscious patient in general, you can either have, there's lots of mnemonics, and sometimes people think this is really hard, but I think it's not that hard actually. Like, from a standpoint of what it could be, either it's focal, if it's like something in the brain, or it's metabolic. And here you will have to do like a CT or maybe an LP, and then even trials of epileptic drugs. Here you'll do a VBG to check for tox. You do an ECG, even do like a review of the toxidromes, maybe give naloxone if you want, and so on. Kidney function, liver functions, and then you have to think about rarer conditions. The thing is, like, so a lot of it is like bedside workup, and then you go for a CT, and then you put the pieces together. The problem is when they don't look like this and the blood samples come back normal, and they don't have anything on your CT, then there's also always a question: should we do a venogram? Should we do an LP on them? And oftentimes, if they're known and if they're like weak from the beginning or frail, then sometimes the answer is no. But if they're young and not known in psychiatry, and like, then sometimes the answer is yes. But it's, yeah. You can always give the Conciella cocktail, like thiamine, glucose, and then naloxone as well. Yeah. Look for gaze deviation in your unconscious patients. think about the light bulb model. Yeah. Just wanted to give you this case as well. It was a case that I have had and where I made a mistake, I think. 73-year-old woman who was biologically aged. She was really sarcopenic, and she had a metastatic, like slow evolving but metastatic cancer that was palliative. She was in a nursing home of some sort, and she had had a stroke earlier, but it was no dementia. But she was in a nursing home because of her frailty, but she was cognitively intact. So she was sarcopenic when we she had a 3A. Saturation was uncertain because we didn't get any measurements. Always think about it that they're hypotensive then. She seems to have apnea episodes, and what the thing is that she has been eating, and then suddenly that just happened that she had collapsed there and then, and no one knew what it was, but the blood pressure was 70/40. She had really weak radial pulses, a pulse of 110, but she was also on beta blockers. GCS of E4. She was having open eyes with a deviation to the right. V1, M1. And focality couldn't really be judged, but she wasn't really, like, even with pain stimuli, she wasn't really moving her arms. She was weak. She was previously weak on the right side, but it couldn't really be shown here now. Didn't have any convulsions. Blood sugar was okay. Temperature was low. Lactate was 8. pH was 7.2, right? So it was like she had a high anergic metabolic acidosis. The ketones were normal as well. So what do we do here? I decided I thought it was actually a seizure, this, and went directly because she was weak on the right side and she was pointing her eyes to the right side. So I thought, oh, maybe this is a seizure, but I forgot to stabilize before moving. She was really in a bad way already. This is peri-arrest. She was apneic, and she did have really low blood pressure, which dropped as well. So could I do it again? I would probably have put on vasopressors on this, but there was lots of factors that showed that it was really hard to actually do this. I came in late in the case as well, and a decision had to be made. So, but yeah. But it turned out like, and it was all like, should we do anything on her? Like, anesthesia was not too willing to actually do much on her either. So it was like, oh, what should we do here? So a hard case, I thought, and but in an idea, had I to do it again, I would probably go for stabilization with pressors, and then go for CT afterwards, because the CT was normal, and we never got she sadly died and coded in the CT scan. So we did everything we could and tried to revive her, but there was she was not revivable. And it could have been a cold sepsis. This afterwards, I would say, like the gaze deviation was probably a seizure because of hypoperfusion of her brain. The blood pressure was so low. And it wasn't just 70/40; it became 40/20 at a moment there, and then this intermittently it went up and down. Like, so she probably had peri-arrest with seizures just before her arrest, right? So that's probably why she was. So it doesn't have to be a neurological cause for seizures, and that's my take home from this extra case here. So you have gaze deviation. Also think about hyperperfusion if the blood pressure is low. All right. This patient, 55-year-old marathon runner who came in, who had collapsed while he was not racing. It wasn't a marathon race now. It was just he was running just a normal trip. It wasn't too warm. Like, a heat stroke was not on the list of differentials right now. So now he complains a little bit of headache and a little bit of vomiting, and he was otherwise healthy. So the history was like the ones who have witnesses have said that he was confused just 5 or 10 minutes. He had collapsed. It seems like he had headache before when we asked him, had sudden headache before, and then he collapsed, and then he was gone for 5 or 10 minutes, according to the witnesses. That's always hard to see. And he was a little bit confused when he woke up as well. When he came in, he was vomiting, but otherwise okay. Only vomited once, and then he was a bit nauseated. And these were his vitals. Right, he was a bit bradycardic. I was like, is this an ACS or is it a subarachnoid head? So like subarachnoid or arrhythmia, right? It could also be other disasters, but we got an ECG. It looked like this. I was like, oh, this at first glance it looks like an OMI, like a posterior OMI. 2, 3, 4. But also 5, and also here. So it's more generalized this. So it's like, what is it? So one of the take-home points here is that 25% of subarachnoids have an ACS mimicking ECG, which is usually characterized by like these cerebral T waves, really deep, big T waves. In most, like, it can be focal, but usually it's diffuse. Then you have QCC prolongations usually, and then you can be bradycardic, and he had all of these. So what do you do? Well, we weren't quite sure, but I put on PATs on him, and I thought like thunderclap headache was more. I was more worried about this subarachnoid, and we have a CT scan right next to us, so we did the CT scan first, and we found this. He had a definite subarachnoid. So 30 degrees, tranexamic acid, maybe hypertonic. There's the bolus of hypertonic saline, and then checking and then giving him like transporting him right away to a hospital that can do something about this. Yeah. So think about the ECG changes in increased intracranial pressure, subarachnoid hemorrhage, and then we've already talked about the acceptable miss rate of subarachnoids, and yeah, I always when we talk about subarachnoids, it's important again this sit down with the patient and ask them a question. How did it start? Because if you're asking them like really narrow questions to begin with, like if you're asking them only like a checklist kind of in a checklist kind of way, then you'll just ask them, did it come sudden and was it severe? And then you'll miss a lot of patients. You'll miss the stoic patients who are in the emergency department who've never been there before, but they will not agree to that it was a severe headache usually. But you will have to know that, oh, they've never been there before and it came sudden. Then that's a stoic patient that needs to CT scan. On the other hand, you have the patients that, they will say yes to both questions, and then you will lead the victim into a wrong algorithm oftentimes. So you have to sit down with your patients, and you can check out the EM Cases podcast where they talk with Matthew Perry about this on the SAH thing, and he says the same thing. Sit down with your patients and then assess whether they live up to the criteria or not. If you have someone just sitting by their computer and then they usually say, oh, it was a really severe headache and it came on sudden within seconds. Okay, tell me, like, what did you do? Oh, I didn't do anything. Like I just continue working. If you don't have to stop what you're doing, then it's usually not a subarachnoid headache, right? But if you want to be totally sure, then do the CT scan within 6 hours. The problem is if they present after the 6 hours, which they can, because then it's lumbar puncture and you have like quite a weak history from them, then it's kind of like maybe not, depends, and that's where you really want to know the extended window of like how sensitive is a CT scan after 12 hours, after 24 hours, and it's quite sensitive after 12 hours, but not so much after 24 maybe. Again, this might be updated after the Shed study, but yeah. Okay, case number 6. Yeah, this was a 24-year-old male with who was tetraplegic after a neck injury 6 months ago, and he not ICs himself. He was catheterizing himself intermittently. He had already been waiting for 6 hours in the emergency department when you come on to night shifts in the surgical part of the emergency department. He came where he was presenting with macroscopic hematuria. But you were called by the nurse because he suddenly screams of headache, which came on over a few seconds to minutes. His airway was free. He had a little bit of high unexpected or respiratory frequency. His blood pressure was somewhat high, but not too much. He had cold. He was cold on his legs, but not on his arms. His abdomen was did not feel. He couldn't feel anything on his abdomen because he was tetraplegic. He had a sensory level around maybe a little bit above the nipples. It was like TH1, 2, something like that. Sensory level about, and they say here C7, something around that area. And then he was like a little bit soft febrile, but no skin changes. His urine was hemostax 2, meaning that it was more like cranberry juice, more than like there's cranberry juice and there's ketchup. If it's ketchup, then usually you have to put in the big drain. If it's cranberry juice, then it's usually not too many not too many cloths, but then you just can spool it and then it'll often resolve. But yeah. He was positive for leukocytes, but not nitrite. He has a lactate of 3, and his blood samples were normal. So, what to do here? Is this meningitis or DIC? Not DEC, the DIC. Urosepsis with an abdominal focus, maybe. Or Hickam sticktum. Does he have an infection and autonomic dysreflexia? Does he have subarachnoid with his infection, maybe? We don't know. This is the knowledge bit here. When I worked in neurology, I had one shift where my professor, before going home, said, "We have this patient on our ward. You need to know about this thing that can happen with him, and if it develops, you need to take off his clothes." Okay, that's a new one. So autonomic dysreflexia is something that can develop in patients who has a TH6 injury or above, so a high injury, and it's because there's a autonomic disconnect, so to speak. So the lower portion of the body, the body part below the lesion, it works kind of autonomically, and you will get a vasoconstriction. You have an overactivation when it's being provocated. So if you have obstipation, or if you have a full bladder, or if you have really tight clothes on, then your sympathetic system will be really tight, and that will mean that you will get a high blood pressure, meaning that you'll get headache, meaning that you'll get flushes to your face, and you will have distended neck veins. You'll become sweaty, and you'll be vasodilated above the lesion, but you'll be pale and cool below your lesion. So the vasoconstriction, so cold legs, warm arms, if that's where your lesion is, right? And so because the stimulation of this of your so the when you get this overactivation below your lesion, then the parasympathetic system above your lesion will vasodilate, so that's why it will become warm there and sweaty. So you get like overactivation of both systems. And what is dangerous here is that you will, when you have such a high blood pressure, you will get PRES. I can remember the acronym was like posterior reversible encephalopathy syndrome, or something like that, where it's the syndrome that people present with if they have malignant hypertension and headache. That's the syndrome we wanted to catch, and it's often CT scan negative. But what you have to do with this patient is, because this is a life-threatening complication. So you have to remove their clothes, remove pressure areas, so you need to like turn them around, empty their bladder, give them clicks, or give them a bowel impaction, what is called bowel enema. Yeah, and position the head high so that they don't have like if you position the head low, then they will have even higher blood pressure, and they might so like head high, legs low, so that the squeeze on the legs is the opposite of a syncope, right? So syncope is like you vasodilate and then you have to put the head down and legs up. Here's the opposite. And then remove all stimuli, empty the bladder, remove the clothes that's tight, and so on and so forth. And then if this doesn't help, then you have to active blood pressure lowering, so labetalol or stuff like that, nicardipine. And you have to monitor them closely. And one of the knowledge bits here as well is that these patients do not have a high blood pressure. They will usually have a blood pressure. Normally, tetraplegic patients will usually have a blood pressure around 90 to 100 systolic. So this patient who had 160, that was hugely high. It's just like preeclampsia. They should not have above 140, and definitely not these patients. So in this case, what did we do? We gave him pain relief. We did all the things, but we do also cultures and antibiotics. We did a CT scan of the brain and the abdomen and the thorax, because we couldn't palpate the abdomen, right? We couldn't know whether it was hurting or not, and it could be a kidney stone, it could be something else, being a more severe case of infection, right? So we wanted to check that out as well. Turned out was nothing other than pyelonephritis, and he didn't develop any press, so the scan was negative of the head, and the scan of the abdomen showed pyelonephritis. And the urine culture a couple of days later showed Proteus mirabilis. All right. Take home, you have to know about this autonomic dysreflexia if anyone comes in tetraplegic or paraplegic and have a lesion around C7-ish, above T6. Yeah. And that the blood pressure of one of these patients is usually low. So if it becomes high, even though it's in normal reference range, then it's high. And you should have to do something about it. Remove the clothes, up with the head, down with the legs. Case 7. In the surgical part of the emergency department, a 59-year-old man arrives with new onset urinary retention and constipation. He's an economist, has 2 teenage children. He has candazatan, which is an ACE inhibitor, and alpha-socin, which is like temulosin, for his PPH. Today, it become successively harder to pee, and he had stomach and back pain. The back pain stemmed from 4 days ago when he when he was lifting something, and then he got a tinkling down both his legs. And now he presents with this urinary retention. So you might already know what this is. This is one of Patrick Croskery's favorite cases. I think he's written articles on it, and it's also in his book. So this bladder dysfunction usually is BPH, right? Because he even has BPH before, and that's But with back problems, always have to think about, could this be a quad equina syndrome? Could also be aortic disease with nerve involvement, of course, but less likely. So, and we also have to think about always with these patients the polyuric phase. Even though we know what it is and it's not dangerous, then you can develop polyuric phase where their kidneys have taken a hit, especially if it's developed over days where their bladder is big. Then if they have, we usually say if they have over a liter in their bladder, or they produce more than 100, maybe 100 to 200 milliliters an hour over a couple of hours in the emergency department, then we have to admit them for polyuric phase as well. This patient had a really big bladder. This is from Nephro POCUS, which is a great homepage for POCUS as well. he was pain relieved when we put in the catheter, but he had like this polyuric phase, so he's not going home. We know that already. But also he had reduced sensory level to his bilateral area, but bilateral saddle area. But it was really important that even before that, we would have to do an MRI on him, no matter what the neurologist showed here, because he had bilateral symptoms with back pain and bladder problems. That's enough, according to the guidelines I will show you next here. So, and we cannot get an MRI usually quite quickly, so we have to call another hospital to actually convince their back surgeons to actually get this. Sometimes we can get it, but not always. And then sometimes when you call your neurosurgeon, they will ask, "Oh, did you do a parectum?" And here's a good statement from the ARCHIM that of particular note is the acknowledgement that bladder scanning and the performance of digital rectal exam has no role in diagnosis of CES, and that access for MRI is the central issue. Yeah, I agree, because the parectum exam for anal tone is really, really bad. Even anal reflexes are quite bad. So you cannot rule them out. They're really low sensitivity. So you might I'll do it if they tell me to do it, but I don't like. For me, like if it's positive, it doesn't matter. If it's negative, it doesn't matter. So it's like, yeah. So don't rely on the digital rectal exam. You should rely on other symptoms. Oh, this is just cross-caries, back pain, like other things that you have to worry about. And it can always be other things, of course. What is the lesion? It could be an epidural abscess, could be always think of the aorta when you have back pain, but you cannot palpate it, so on and so forth, right? But you can check this out yourself. Here is the consensus from the WFNS Spine Committee recommendation, and I think cardiac quine is really, really hard because we don't have an MRI. So really, and there's 22 or there's several. There's lots of definitions of what cardiac quina is, and they came to this consensus in 2024 because we cannot have so many definitions. So they settled on this, the Lavie definition from 2022, as I understand it. And then here they talk about suspected CES, no bladder bowel symptoms, but bilateral sciatica or motor sensory loss in legs as a clinical CES or known large disc herniation. Then they go on the article to say this needs MRI. And then there is a symptom only, normal bladder, bowel, and so on, but some sensory loss in the perineum. And so this might be our patient, right? Micturition frequency maybe, or an incomplete alteration. This is our patient. Alteration in bladder and neurological sensation, function but maintenance of exegete bladder control, plus minus perineal sensory changes or sexual so on. And then you have the CS with urinary intention. Yeah, maybe even down here we are. And the thing is, as I understand it, if it's a complete one, then they're in no hurry because then it's too late. If it's a early one, then they think, this is not it. Don't do an MRI. So it's really hard to pick the right time for these CES patients. If you don't have an MRI, it's really hard to convince someone to take your patient. So the best thing would be to have an MRI in-house. But as the ARCHIM 2024 statement said, it's the MRI time to MRI is the central issue here, and that's the problem for me as well in my department. Okay, but take home here is if you have bilateral symptoms, especially, then and bladder or back pain, then you have to think about this. Bilateral symptoms is one of the hallmarks. All right. Case 8. 25-year-old man hospitalized in the psychiatric ward for 2 weeks because of a drug-induced psychosis. He was treated with olanzapine and a lot of other drugs, Haldol and so on. He came from psychiatry because of confusion. He's otherwise somatically healthy. So when he came, he was really, really agitated. It was not possible to get a needle in this patient because he was not he wouldn't do it. He was too agitated. It was like screaming and all. So what do you do? Well, method 1. Voluntary, always try to de-escalate and give it voluntary, but if it's severe agitation per Ruben Strayer's definition, in EM cases he goes through these definitions. If it's severe agitation, it's not possible per definition. So you have to sedate them, and then it's like we have to claim what we call nöd in Sweden or in Scandinavia, that I'm trying to save this patient's life, therefore I'm doing something against their will. You don't have to use the psychiatric law here, I would say. You just have to do it because to save their life. So you have someone holding them down, and you have to sedate them, either with help with anesthesia. There's different methods. If you're in a place that uses ketamine, you can use ketamine 5 milligrams per kilo intramuscularly, and then you always, because it works only like for 20 or 30 minutes, you have to also cover them with olanzapine or midazolam for that more lasting effect. Then method B is to make the anesthesia do propofol sedation. That's what we usually do. Then method C is olanzapine or haloperidol. It will take some time, and you have to hold them for a longer time. Remember to put something on their face, because they might be spitting, but they might also be hypoxic. So putting something on their face is like a spit shield, like a shield for spitting, but also oxygen. So that would be a good tip. And then method 3, psychiatric, not coercion, but the law of like where you can force them because if they're psychotic. That's usually only for treating the psychosis. And if they're not psychotic here, but it's more a somatic thing, I would say like just say that it's distress, have the nöd, and then just do it without that. And then you can always do it afterwards. But this takes a while usually, so do this first. And then once we got that, and he was profusely sweating and had a high temperature, and he was really rigid, and he had no reflexes. So he was like a hot and altered toxidrome, right? The hot and altered toxidrome, Fui's figures is amazing, and they talked about it in the EM Cases Quick Hits EP episode 36. There you have the medical causes, the heat stroke patients. I just did I just did a video on heat stroke. You can check that out. But in general, that's usually circumstantial. But they were treated the same way as these patients in many ways. Then it could be infection, like especially CNS infection or sepsis, and then the rare one is thyroid storm. But the mainly these hot and altered patients, they can be like a toxidrome, and there are different toxidromes, and we'll talk about those. So in general, these patients who has fever, and it's important that these are hypothermic, but they're not feverish. Paracetamol will not work. They have to be actively cooled. And then you'll have to be sedated if they're severely agitated. And then one of the few times in a resus bay where you have to check for reflexes, clonus, and tone pupils to check what toxidrome it is, and you'll have to do the toxicological handshake, which is a handshake in the axilla, to see if they're dry or wet. And you do blood gases, and then empirically you'll treat them with benzodiazepines, because that's usually the treatment for most of these. And it will also treat the the hyperthermia, because the hyperthermia in toxidromes is because of muscle shaking. So muscle relaxants will reduce that, and they will become less agitated. So benzodiazepines is the backbone of all toxidrome treatment here with the hot and altered. Then you have to actively cool them. How do you do that? Well, it's important that you have some plan that is local. What we usually do, because we don't have, like, unless it's snow outside, we don't have ice. Though it has happened that we shovel snow from outside if it's warm, if it's cold outside. But what is optimal is that you submerge the patient in water, and sometimes you can have body bags. They have that in New York sometimes, that where you put the patient in a body bag and then you put ice and water in that. But what we do is that we have a lot of towels. We have a sink in the resus bay, and then we just take like 20 towels, and then you just, once the patient is sedated, then you just get a lot of people to like get a lot of towels, like remove all the clothes, and then get a lot of towels on the patient with wet, like cold water, and then you'll just These towels, as you put them on the patient's skin, they will dry up, and then you'll have to like remove that towel and go to the sink again with that towel. So you have to like have like a routine where, or you have to have someone going in circles here, removing towels, putting them in the sink, getting new towels, putting them on the patient. And then maybe with a fan that doesn't really do that much in addition to those things, but it's really important to do that. And then the thing is, like, as much of the patient's skin surface area has to be covered as possible. That's what counts, right? So that's what we do. Then we have to give them fluids, not liquids, but fluids, cold fluids. Again, AI, sorry. And then consider D plus R, that's the Danish way of saying it, but cultures and antibiotics if they have meningitis. Consider whether they need a lumbar puncture. And then aggressive treatments of not cramps, but seizures. Because if they seize, these patients, they become more warm, they become more muscle tone, they become more acidotic, and this is a vicious spiral into death. So it's really important to aggressively treat the seizures. Then once it's more stable, you can begin to think of which kind of toxidrome is it. The reason why this is later is that, well, you need to treat things right away because they have a high mortality, these patients, if you don't know, if you don't start treating them before you know what it is, and you might not even know what it is after a while. But okay, there are some. In general, there's these there's two big groups. There's the one that are quickly developed, and they are usually with hyperreflexia, and they may have clonus. They're usually wet, and if they're wet and they have clonus, then there's usually serotonergic serotonergic syndrome. If they are if they don't have too much clonus, it could be amphetamine, like the sympathomimetic syndrome. If they're dry, and then anticholinergic, and all of these, it's benzos, right? And cooling, benzos and cooling. And then sometimes you might need a more specific drug. If the patient is anticholinergic and you have a widened QRS complex, then they will need bicarbonate acutely to reduce that. If they are really agitated, then you can give them physiostigmine to ease the way that they're to ease their how you can handle them. But the problem is you cannot get the physiostigmine if they have a broader QRS or any arrhythmia risk. So don't do that, and there's no mortality benefit in giving that. So benzodiazepines, we use olanzapine for the next step, and then physiostigmine maybe. Same thing with serotonergic syndrome. It's benzodiazepines and then maybe olanzapine as well. And then there's a third line which is used internationally, but not as much in Sweden. This patient, however, was not quickly developed. This was over time. It was developed, and he was hyperreflexive, almost Parkinsonistic, and had bradykinesis. Even though he was agitated, he also had bradykinesis when we examined him. And this can be either malignant hypothermia or neurologic malignant syndrome. And these patients are maybe the one that is important to pick up. Scott Weingart just did a episode on this with neurointensivist Vidic, and you can check out the episode. I think it's 400. And the thing is, you have to treat them with dantrolene. Malignant hypothermia is very circumstantial. It's very much context based when you're when you're sedating someone in the OR. That's when you get that. And of course, you need to think about the other things in the hot and altered thing. And also in these patients, you need to take CK for rhabdomyolysis. All right. So all of these patients, hot and altered, benzos, cooling actively, not only with paracetamol because that won't work if it's not an infection. Aggressive convulsion treatment also with benzos and Keppra, but avoid phosphatidylcholine if possible because you cannot give that with arrhythmias, and some of these have arrhythmias. So then consider cultures and antibiotics. Okay. And these patients is one of the few patient groups where you want to do reflexes and clonus and check the pupils and so on. Okay. and know how you're going to handle a severely agitated patient in your ward. You heard my method. You can check out what you want to do in your department. Okay. Case number 9 here. 19-year-old man comes to the emergency department with his parents due to a fumbling gait. He had impaired sense of touch and difficulty concentrating for about 2 weeks. He was studying at university. He didn't have any overconsumption or anything, but he did party in weekends here in Stockholm. When we tested him, ABC was okay. He had a GCS of 15. He was a little bit slow cerebrated. He was walking with a broad gait. Definitely not normal for a 19-year-old. He was Romberg positive. He had impaired sensory function in his legs for touch and proprioception, and he had bilateral pathologic hyperlipexia. You might think, where's the lesion? Well, so he had symptoms on both sides. He has no back pain, but it could be a myelopathy. He didn't have any bladder symptoms, but he also has some central symptoms, like he's a little bit off, right? So is this one of these rare neuroinflammatory central syndromes like ADEM, ADEM, or is it like an encephalopathy of some sort? Is it a viral encephalitis or something like that? Or is it anti-NMDA encephalitis, something like that? Well, this is all about this being in Stockholm, because we have quite an epidemic right now of something. So we've seen a lot of these, and what we want to do with these is to take a blood sample. We want to take the anemia profile and homocysteine. So if we check this homocysteine, it was very, very high. Above 50 is where we want to often draw the border here, and he has 108. So he has with high certainty a nitrous oxide overconsumption, which is used at parties here. And it's still free to buy, but there's a law coming that will put a ban on it and make it illegal to buy big quantities of it. What it does is that it inhibits B12. But the B12 is usually normal or maybe a little bit low, but it's not sensitive enough to take the copylamine or B12, so you have to take the homocysteine instead. That's why. And my girlfriend, who's in hematology, she will usually tell us that even no matter what the reason is for homocysteine, you will develop you will be thrombogenic if you have homocysteine. So these patients have to be treated like follow. So first of all, they have to be hospitalized, often for 3 to 5 days, so that they are absent so that they cannot take their nitrous oxide, because they will do that, because their brain is usually in a bad state after taking these, and they're kind of hazy and they're kind of slow, and they don't know what they're doing, kind of. You cannot expect them to actually not take it when they come home. Also, and the treatment is quite good and quite easy. It's B12 vitamin intramuscularly, but if they keep taking it, then it will not work, and it might even worsen their symptoms. So it's really important that they do not take anything ever more, but at least not for the 3 or 5 days there. Then you have to do an MRI, at least here in Stockholm, because if they have a cervical or thoracic lesion, which they often have, then they are gold for rehabilitation. And you keep them in the hospital until they are normalized their S-homocysteine. You don't just have to give them 1 dose of this, 2 milligrams of IM B12, and then you have to check the B12 that is in the upper limit of the normal range during the stay. You'll give them prophylaxis for LMA, like low molecular weight heparin, and if they go, then you'll revoke their driver's license if they have one. You will notify if they have children under 18, or if they themselves are under 18, and then in Sweden you have what you call lag I can't remember right now, but it's like you you can put them in a facility for drug use if they cannot free, like if it's life threatening what they're doing, and they you don't think they can be abstinent by themselves. And the thing is that it's different in different countries. Here in Sweden, it's not possible to do it on nitrous oxide, but the law is coming that might make it possible. And then it's important to tell patients about that. And sorry, it's hard to read this, but it's important to tell the patients about this. Like these are young patients, young people who has their entire life in front of them, and they're doing this. All drugs are problematic, but this they usually use, like it's really common for almost everyone to use this at parties, and they don't know how dangerous it can be in large consumptions if they consume it in large amounts. They do have to consume it every weekend for a while before they get symptoms, but they will get symptoms oftentimes. And if they do, then it's usually a spiral down towards myelopathy. And the problem with this is it's not always reversible, these symptoms. Especially the bladder symptoms are not necessarily reversible. So we have young people having to be in wheelchairs or walking awkwardly the rest of their lives and not being able to pee, or maybe even have like a normal bowel function. And it's really sad. Then and then also you have, like, if you do have a patient with a homocysteine with above 50, even though they don't have any symptoms yet, they might present with like, oh, I have this drug use. Can I be helped with it? And yes, it's really important that that's a severe usage, and then they have to get help right away. I just wanted to show you that you can buy this on your internet still. It is going to shut down soon, but you can still buy this, and yeah, it's like 900 kroners for one of these big ones, or 300 for this, and you can even get an entire like an entire euro thing here for 222,000. Yeah, it's a lot. And all around my neighborhood, we see these everywhere after weekends. Okay. Last case here. 72-year-old woman who is seeking with double vision. She had these symptoms, these diseases. And she had 3 days of binocular double vision, initially intermittent, but now constant. It was vertical diplopia. She had temporal headache as well. What do we think this is? You see, your colleague says that, this is a handover. So, and the handover plan is, again, thinking about the plan before you actually like fly ahead of the plane, right? But his plan was that, okay, if CT scan is normal, then you can just send a patient home. Are we in agreement with that? Well, I'll go back to this headache slide I usually use. So the important thing is, again, these are the ones that the CT scan will truly rule out. In some circumstances, these can also be ruled out with the CT scan, as well as space-occupying lesion, but not like IIH, like idiopathic intracranial hypertension, is not something that can be ruled out, but space-occupying lesions, oftentimes the big ones with tumor, yeah, they can, with tumor edema, they can, but not the small ones. And in this case, well, all the extracranial ones, temporal headache, double vision, that's PMR, or that's GCA, giant cell arteries until proven otherwise, right? So, but there are other ones as well. If you have a diplopia and headache, you always want to think about, could this be a cranial nerve 3? And that if that is newly developed, then it could be a aneurysm that is about to burst. So what do you do here? So you have a patient with diplopia. If it's monosymptomatic, of course, then you'll think, is it monocular? If it's monocular, then it's almost always an optic thing. You can use the pinhole test to see if it becomes better and refer them to ophthalmology. But if it's binocular, meaning that each eye looks normal or sees normally, but if you have this the gaze, if you look with both eyes at the same time, then it'll look double, meaning that the gaze is they're not aligned, and sometimes you cannot see anything, even though the patient has symptoms. You will not see anything when you look at the eyes. So that's really important. That's why it's really important to ask them: is it vertical or horizontal? Meaning that do they see like two things on top of each other in vertical or beside each other? Because this leads to this down here in a minute. Is it constant or is it fatigable? Right? Is there myasthenia gravis in this, or is it CIA in this? And other symptoms as well, of course, but it wouldn't be if it's monosymptomatic. It's also important to say, like, is it in all directions? But because most of the true reasons for these like things, they are like they will see double in some areas of the vision, and like when they look to the right or look to the left or up or down, but not in they will not have the symptoms in all directions all the time. That would then I would usually think that it's not too specific, right? All right, so then you go on to examine them, and either it's a cranial nerve problem, then you can have a CN3, like a cranial nerve 3, which is usually down and out, with a usually with a pupil that is enlarged. And if they do have that, then the dangerous thing that each of these have a dangerous diagnosis that you need to know about. And one for the CN3, it's a aneurysm, so you need to do a CT angiography if you think that. And these will like have a vertical binocular diplopia. If you have a CN5, 6 abducens, then they will look a little bit in towards their nose when you're looking straight ahead, and when you make them abduct their eye, they will not be able to. Then they will have a horizontal diplopia. And for some reason the cranial, like the abducens cranial nerve, has some kind of it's prone to be deficit in increased intracranial pressure. So we might think of conditions with intracranial pressure such as IIH or CVST. And then you have your trochlear nerve. Usually they have a nasal upward shoot when you look immediately with them, and they will have like a vertical diplopia as well. These are usually not that dangerous unless they're symptomatic with other symptoms. So if they have other symptoms, other motor or sensory symptoms, then you would think about this being a brainstem lesion, right? Go back to the rule of four, Gates' theory of rule of four to go into this in more detail. You can also look up Tim Root's really great videos on cranial nerve palsies. Check that out. Tim Root is great. And also, if there's multiple, you can really not figure it out, but there's definitely something wrong with the eyes. Then it could be sinus cavernous syndrome. And there's other syndromes as well. You can have INO and stuff like that, but these are the main ones, right? Then you have mechanical ones where it's not a nerve palsy, but something that's pushing on one of the eyes. It could be a tumor, it could be a trauma where you have what you call a trapdoor fracture. And that's why you always have to, like, if you have a facial fracture, you always have to check the eyes to see if there's a trapdoor fracture. If they have binocular double vision, then usually it's somewhat urgent to operate on them because the muscle can become ischemic and they will have permanent double vision. Could be metabolic, like a thyroid condition, and it could be myasthenia gravis. Could also be GCA. So what do we do with this patient? Well, they don't really have this necessarily, but usually GCA is usually because of ischemia, and then they have one of these. But there was a pupil sparing in this particular case. You could have done a CT angiography, but here we did CRP and SR and showed that they had a high CRP and SR, and they even had that temporal headache and and the SR and the CRP was high. So we diagnosed this patient with GCA, probable GCA. We don't have a rheumatologist on call, so what we usually do during the nights or evening shifts, especially it's problematic if it's a Friday, because then the rheumatologist only comes on a couple of days after. So, and if we do get them prednisone, these patients, the sensitivity of the diagnostic test like biopsy or ultrasound becomes less. You have a couple of days to go on, but it's always hard if it comes in on a Friday. All right, but what you do is that if you have a GCA with eye involvement or at least vision loss, then you will give them pulse dose, which is like 500 or 1,000 milligrams of prednisone, which makes them psychotic, which means that they have to be admitted, especially if they're elderly. And all GCAs are elderly, above 65, most of them, a few above 50 years of age. But what you could do, if you don't have a rheumatologist to ask, these are eye symptoms, even though it's not vision loss, it is eye symptoms, and I would probably just give the pulse dose. Then there's always the consideration of, should we do a CT scan of the aorta? I've heard some rheumatologists sometimes want that, depending on what kind of symptomatology they have, because some of them have, it is a giant, it is a big vessel inflammation, and sometimes they do have aortic involvement, and I cannot really figure out when to do that or not. It usually is not that we have to do it, but if they have claudication and other things, then sometimes ask your rheumatologist. Then just last slide here is that I wanted to show the CT negative headaches as an example. These are the 5 ones that EM cases want us to think about. There are others, as I showed in the other slides, but yeah, always think about that when someone is handing you over a CT scan and go home. Then think about these. All right, so that was that. Thank you so much for listening and viewing, and I hope you made it all the way here. If you have any questions, then please ask in the comment section, and contact me if you want to check out Stockholm and see how we work. All right. Thank you so much for making the world a better place, and see you next time. Bye.